talk, so.
Goodies, man.
Oh man, Coralie's gonna be real mad.
Well, she may be even madder because we've had some theft problems here
Yeah,
recently.
that's what she's saying last time or time before.
So. You didn't get your pals book, did you?
I did not.
Let me go grab you one.
I didn't get mine either.
No, you didn't either?
No, I wasn't
Let me
here
go
about.
grab a couple of them.
Okay, thank you.
Howdy.
I think BTV's upstairs, man.
Yes?
Yeah.
Gotta walk upstairs again?
Sorry.
Shit. Is this the MTA class?
Yes.
There's a birthday party for me here.
Surprise!
Oh, thank you, bro. Now I feel good again.
Happy birthday!
Happy birthday to you.
The cake's in the other room over there.
Well, Justin brought it. I'm not Justin, but Brady brought it last time, the little checks piece.
Yeah, it was pretty good too, actually.
That was adorable.
Yeah.
Yeah, he makes good cake.
Well, his girlfriend does. Yay for payday.
Yay for payday.
Sir,
Sign your life away?
you got it.
Thank you.
Yep. Sign away.
It's not legible, do it in print.
Still gotta figure it out.
We'll probably be able to figure it out.
Thank you.
There's a pretest. You can take it anytime. It's just,
Same as the.
yeah, same as the ACLS, it's like on the second page or something. Don't worry about your score, the score doesn't matter at all. It's only for your information to kind of show you where you're at. It's just for you, it's not for us. We don't care. I know it
You don't care
says
now.
take the pretest and you have to have a 70 to have the class, blah, blah, blah. No, that's not accurate. The pretest is for you to give you an idea of where you are and what you might need to study. Boy, yeah, maybe you should have printed your name, Zach.
I still can.
No, I'm just kidding.
My signature just have to scribble. Well, at my other job, I pick up shred bins, and I've got to sign like 50 tickets a day.
Oh, geez.
So I've developed a signature that's very,
Right.
that can be done very fast.
Yep. Well, good. That's the way to do it.
Not only that, when they can't read it, I can just deny I did
How
it.
are
Yeah.
you doing?
I didn't do that.
Yeah.
What?
How are you doing?
Wow, great, how are you? Wow, three.
Yeah, we have kind of a small class, so I think we'll give it a few minutes and see if anybody else shows up. Nobody has signed on to the live stream yet. So,
We live stream this?
yeah,
Oh,
oh yeah. Oh, there's the other box.
yes.
I looked for it, couldn't find it.
Well, thank you.
I thought, uh-oh, it got stolen too.
Yeah, I have a secret hiding place now.
Did you get a Pals book? Okay.
What's that?
Just making sure everybody got Pals books.
I got you, but did we not do the free test? I did. You got on the
It's all right. Not horrible.
Did you get that last
Actually,
class?
no.
Yeah, did you go now?
The rhythm's the one
Yeah.
that keep my thumb on it.
Oh, is it?
Yeah.
Let's see. Yeah, I don't see that. There you go. Sign away.
Got it.
So was it different people than you, or somebody that signed up first? I thought it was the same person. I missed that.
So there is a pre-test. It's in the ACLS, don't worry about your score.
I go online and do it.
It's mostly, yeah, no, go online, there's instructions in the second page. It says you have to have a 70% or better to take the class, that's not true. The pre-test is just, your information to show you. So if you get a 30% on it, and by the end of the class, you're going to 70 to pass the test. Everybody signed in? Nope.
So far. Yeah, we got a second one for that then, and then one, and then.
Has anybody other than Brandon taken the pretest yet?
Are you gonna have them do that today?
No.
Oh,
Might as well get started. It's,
Mine's pretty short, cause it's all stuff they put down.
yep. Yep. So, PALS is just, it's kinda like ACLS, except that a lot of the stuff pertains to infants and children. So a lot of the stuff that we're talking about, that we're going over, is the same. Rhythms are the same. So as long as you've learned your rhythms in ACLS, you should be fine in PALS. It's just a review. 90% of this stuff is review stuff, especially from ACLS. So, Dallas is going to teach you the first 10 minutes.
Mine's really not so much a teaching as a refreshing.
Yeah.
This is all BLS stuff. So, printing off opportunities. But I just printed off some of our very specific pediatric protocols, so you guys could have them as a quick reference. But some of our big things with kids, AHA is constantly changing our CPR ratios so that we have to buy new books and posters every couple of years, right? So their current guidelines is for a 1 rescuer, a 30-2 compression to breath ratio, 15-2 if you have 2 rescuers. That's what I pulled up on the current guidelines. But like I said, that changes every couple of years. The big thing with kids that I personally think is just using some of the resources we have. One of the big ones are Broslo tapes. So I brought one of these down, and I'll keep it down here for today as well, because this is actually from one of my bags. But just using the resources we have. So remember the Broslo tape, the green we put at the head, and then we measure wherever their feet lie is the where on our Broslo we're going to be working from. So if we go to our white, we've got all of our medication doses, things like that are all right there. So it's a great resource, especially in our PALS. Use it in your testing because it helps. All your answers are right there. Okay. The other thing too, I don't think that the Broslo tape actually has it, but just understanding our pediatric baseline vitals. So I have a little card in the back of my phone that's got my pediatric baseline vitals ranges broken down by age. Just so that you can have a quick recognition and a quick reference so that you know when you're outside of those ranges. I am more than happy to make some more of those cards too. I took the card that Primary Children's has and actually made it off of that one. So it's a little bit different from our protocol, but I like it as a quick reference. The other things too, so the assessment one is pretty self-explanatory, right? Just coming into our pediatric assessments, and there's some of those ranges there, and then it just emphasizes on the Broslo. So if we jump over to the second page, our fever management, especially as we're coming into, cold, flu, RSV, all of those kind of seasons. With sick kids, we get our febrile seizures, right? We'll get called on those quite a bit. So by our protocol, we do our acetaminophen, which is at 15 milligrams per kilogram. And then we can leave the bottle with the family and instruct them on how to follow up with their care provider, and then giving additional doses every 4 hours, right? And they can alternate acetaminophen and Motrin as long as the kid's older than 6 months old, right? What's our concentration? Do you guys know off the top of your head what our concentration is on our acetaminophen? I think it's is it 10 milligrams, 15 milligrams per ml? What's our concentration on our liquid acetaminophen?
well, I can get a box and pull it out for you.
Yeah, I always look at it. It says this here says 160 milligrams per 5 mLs.
Yeah, I don't know what ours is on.
Yeah, so it says 160 per 5 here. I know, like the infant one that I just bought for Austin, it's got 100 milligrams per 5 mLs. So the concentrations are going to vary, so make sure you're paying attention to those. And then just know, I know we had a thing last winter where people were giving acetaminophen and the ibuprofen at the same time, and that's not in our protocol, right? You're going to give one or the other, not at the same time. And then the ibuprofen, very specifically, if they're not at least 6 months old, we're not supposed to be giving that one. Okay, so we're not giving them at the same time. Make sure you're giving them separate, and if you're giving the ibuprofen, make sure that they're older than 6 months. Okay, and I think the acetaminophene's on here too. Yeah, so the Broslo even has their acetaminophen on it. Oh, sorry, Julie.
Sorry, I was late. Introduction.
You're fine.
Are these
Just,
packets?
yeah, it's a packet. Or it's stapled together. Oh, nice.
Sorry.
Stapled, paper clipped. Any questions on fever management? Well, like I said, it's real quick. This is all basic level stuff, okay? Then the children with special health care needs was the next protocol that I put in there. We're going to have a lot of unique things. So with feeding tubes, trachs, things like that, I always like to use the parents as a reference because they tend to be pretty well dialed when their kids are sick on how to management, things like that. I've even taken, what I've done in facilities, we've taken the parents in the back of the ambulance with us as well on a lot of these kids, but use them as a good reference. And then a lot of it's going to be a case by case. And it has on here to look for the chirp bags. I've personally never seen one in the field. I've just seen the pictures of them on the poster. And there's one hanging up right there that apparently some kids have these chirp bags, and that's just supposed to have all their current medical information in it. So you can look for those or use your parents as a reference. The last thing that I threw in here is this hand-heavy system. So there's Dan's hand traced for you guys. I actually made this quite a while ago and just copied it off this morning. But this is just another pediatric reference. My brain doesn't work this way, but a lot of my coworkers in Saratoga have actually really liked this. So it has the 1, 3, 5, 7, and 9, and then 10, 15, 20, 25, and 30. And if you look down the dosages, it's in mLs. So that's why I'm saying my brain doesn't work this way, because I always think of medications in milligrams rather than in volume. But if you're one of the people who do think of medications in volume, it's actually a pretty neat system for a quick reference, because if your patient is 3 years old and 15 kilograms, you have a 0.15 ml dose, or a 1.5 ml epi dose, 1.5 ml amiodarone, and bicarb NS, all of those. So if you think of it in volume, it actually could be a pretty useful system for you. Other than that, like I said, it's just a really quick BLS review. All of the ALS stuff Maxwell's going to be going into with you guys today. But I'll leave the Broslo tape up here, and then this acetaminophen, I don't know if it's even the same concentration as our current one. This is 160 per 5 mLs.
You can just pass that around.
So, and then the ibuprofen is 100 milligrams per 5 mLs. The new one's blue. The new ibuprofen is like the blue raspberry flavor, and it looks delicious.
Have you tried it?
I haven't. Because when it came out, I was pregnant. You can't take ibuprofen. But it looks so good. Anything blue raspberry, right?
No, whole case. That's
Yeah.
a truckload.
And we can take out both the ibuprofen and the Tylenol. Even if we're only giving one, we can take both of those out and give them to the families. It's a one-time use thing. I refuse to stand in front of the live stream. Just completely refused.
I think you can just take it and you talk.
Yeah, they can still hear you.
Sorry if you can hear me talk. I don't think anybody's on there though. Alright, I don't know where Maxwell went. That's all I got, the BLS review.
Okay, so how, has everyone been able to get to their pre-test yet?
No.
Yeah. So try and get that done over the next week, over the weekend. Don't worry about it requiring you to have that 80% or whatever it wants in that. You guys just need to, thank you. You can email it to me or just give it to me, and you can, it'll just help you be able to take the post test, really. That's what it's gonna do. Maxwell gets down here, but part of my lecture, let's extend and say, where are you? So, for the policies of UFA, they want you guys to use a Brazil tape, and there's one in every single drug box. However, I'm still going to teach you like a quick way, because if you don't have your Brazil tape or something's going on, there's a really easy way to figure things out. So, so at this point, I'm trying to get Dr. Rowland to give me a definitive answer today to see if you guys can start functioning at your level ASAP. And whoever else is a green patch at this point. The District 2B protocols are now updated with the green patch, what a green patch can do. So everyone go, for this point forward, just go ahead and look up District 2B and make sure that it's, it'll have like ran by Jack Mearsman. It'll have like a bunch of our ambulances kind of just go across the front of it. You can get it right on the... It's not yet, but after looking at it yesterday, I think that we're just going to go ahead and connect right to that and then talk about the Dr. Rowland nuances. There are some Dr. Rowland nuances that's out there. So, I don't know if we have a variance at this point, but I don't think that you'll have to really worry about that because you'll usually have a paramedic there at this point. In Utah County, if you're a green patch and you have someone you want to give pain management to, you do not even have to contact medical control, and you can go up to 20 milligrams of morphine before you even have to contact medical control. But for some reason, the District 2B protocols, they tighten that down, and they want you to contact online medical control, and their max is 15. And they titrate by 4s, which to me doesn't make sense because my thing comes in 10. So I always push 5, and then I push another 5. So so our protocols go from 2 to 5 titrate, with little nuances like that. So now I want you to drop everything you're doing as far as the adult drugs and look at your peds, okay? And peds are always done in kilograms. So a big, an easy way to, this is down and dirty, easy way. 100 pounds, cut it in half, 50 kilograms. 200 pounds, cut it in half, 100 kilograms. So, 250 pounds, maybe my weight, right? Actually, it's 246 because I was so happy today. All right, 246, yes.
Kilograms working.
Yeah. So what? How many kilograms? Just cut it in half. All right. So and I don't care if you round up. So here's the thing: the Brazil tape, even if you round up or round close to it, it's pretty darn close. Go ahead.
If you're part of the predominant religion around here, I was always taught cut it in half and take your tithing out.
Yeah.
Because you take out an extra 10% too, because then it's more accurate. It's divided by 2.2 technically, right? So cut it in half, take your tithing. Also works if you can think that way too.
So, I mean, however you do it, it's easy for me just to cut it in half. And the thing is, you don't have any scales on your ambulance anyways, right? So you're not going to say, man, I'm going to look at you and say, $1.47? All right, $1.80? Okay, $1.80.
He's like, thank you. I'll
Yeah,
take
all
it.
right. So, okay, so there you go. You're swagging it anyways. And swag means scientific wild ass guess, right? Okay, so it's not an exact science. That's why they like the Brazil tape, because they think that's more exact. But when you see, when I try and mess with these numbers a little bit, you're going to see, throw down my calculation, throw down the Brazil tape calculation, it's so close, it doesn't matter. So like epinephrine, right? All I have to say is, boo! I know all of you right just had felt just this adrenaline surge go through you, and that epinephrine went through there. Well, that's a natural product of our body. So a little too much, a little too little, is it really going to make that big a difference? No. It's going to make the heart pound, right? That's its job. All right, so I try to look at our pediatrics, and this is just a down and dirty way. I don't look at kids in their age groups anymore, except for 2 age groups. They're only a 1-year-old, a 5-year-old, and a 10-year-old. Okay? And if you want to swag it one way or another, if it's a big corn-fed kid that's 10 years old from Harriman, right? And he's still 10, but he's more like 6 foot, 10-year-old, or even a 5'8", 10-year-old. He pushes himself into adulthood, right? Even though we're still going to consider him a ped, but his weight now as a 10-year-old, I'll talk about weight in a second, but that could push him off, way out of our 10-year-old range. And when we look at this, we're only going to look at kilograms, all right? So, well, I'll do pounds first, but I think at the end of the day, you don't want to do pounds anymore. You just want to go into kilograms. Figure out the pounds, switch to kilograms. And again, I don't want to do 2.2. Cut it in half. Simple as that. I mean, you're talking a few pounds at the end of the day once you've done your swag. All right, so a 1-year-old, they want to, how many pounds usually is a 1-year-old? They're born at what, 10 pounds, 8 pounds?
20 to 25 pounds.
That's a big baby.
Yeah, okay. So a 1-year-old, roughly, anyone have a kid 1 right now? Anyone have a nephew, niece?
20, 25 pounds.
20 to 30. But
Okay, so let's call it,
They're 20.
yeah. So I'm gonna go LBS, right? LBS. But I'm gonna completely take that out, right? So we'll call them 20, and then maybe 30 pounds for a 5-year-old. Wait a second. 10, 20, 30, 40 pounds? 40 pounds for a 5-year-old and 60 pounds for a 10-year-old. Okay? Everyone pretty good with that?
Yeah.
So we're going to cut that in half. And the only one that I want you to remember, this was 10, 20, 30. I just cut it in half. So now I'm going to take that completely off because the pounds just now confuse you. All right? So we'll go kilograms. All right. So now all of our drugs at this point are going to be weight-based. And there's a, so everything we do with them is milligrams per kilograms. All right. And so I'll just take this real quick part because I'll talk more about it at the end of the day for the lecture. So we look at our 1-year-old, 5-year-old, 10-year-old. So really, as far as kilograms, I have not a huge, I have roughly 10 in between here of kilograms. Not a lot. So let's look at epi. What is the epinephrine dose for a pediatric? 0.1? You guys look it up in your book. This one always messes everyone up. Epi always messes. Pediatric. And the way you do your math is going to be something that kind of freaks you out a little bit. What?
0.01.
0.01. All right? 0.01 milligrams per kilogram. Now, okay, 0.01 times 10 is what? 0.1. Okay. So we're doing epi. All right, so that's 0.1. What would it be here? 2, 0.2, and 0.3. Okay, so now I'm going to even make it easier. Where'd John go?
Run away from me.
Can you get in the cage?
No, it's not. I'm gonna do that.
Here, use this.
grab, epi 1 to 10, like 4 of them. Or I don't know, yeah, a handful, okay? All right, so when we look at our epi 1 to 10, it has increments all the way up to 10, right? It has a 0.1, 0.2, 0.3 on the hashtags. I'm going to show you that here in just a second, right? So you will never screw this up because you're going to pull out your 1 to 10 and you're going to say, okay, I know my dose is 0.01 milligrams per kilogram. But if I'm only doing a 10 or a 1-year-old, a 5-year-old, 10-year-old, I don't care. If it's a 7-year-old, put them up to 10. I don't care. Put them to 5. I don't care, because your drug dose is just barely off on those ones, and it's not going to make that much difference. And I'm a big go big or go home guy. I'm not going to hurt somebody. I can't overdose someone on 0.00 of an epi, right? So I'm either this. So if they are 7, throw them to 10. If they're 2, go to 1. If you're worried, right? So just round up or round down. That's just your quick math. It's just down and dirty. So on your drug, you're only going to give 1 hashtag, 2 hashtags, or 3 hashtags. Boom, done. You cannot screw it up ever. It's that easy. And so once she brings that in, we'll go with that. Okay. So I've got a 10, 20, 30. Okay. So let's do. All right. The way I memorized this was anything that kills or can bring you back to life is 0.1 milligram per kilogram. So morphine, what's the dose? Okay. Narcan, 0.1. Okay. So that's why I just, these are the simple ways of me doing it in my head. Okay. So anything that kills is 0.1. All right. So what's Versed? Okay. So we're seeing kind of a theme here.
Brings you back. I like that.
Yeah, so if it kills you or brings you back, it's 0.1. All right, so then there's one that's kind of a little bit crazy, not too bad, but so let's go diphenhydramine. Yeah, it's 1 to 2 milligrams per kilogram. It's not a 0.1, right? So if you want to stay with 1, I'll just put it back to the 1, so I don't have to memorize any 0.1s or anything. Everything's 1, right? So I can't screw that one up. But that was not 0.1. That's 1 milligram per kilogram. So diphenhydramine, how many milligrams would I give a 10-year-old? 30, right? And what is the dose for an adult? 25 to what? 25 to 50. So, man, I got them half dosed already, right? Now, figure this. Okay, cool.
I just brought all the presentations
cool.
so that we had it.
All right, I'm going to open a couple of these ones. And what else we got? You want to grab some hardware too?
Oh, yeah.
All right.
What else do you need?
Nothing, just, hey, Dr. Rowland, how are you doing?
Oh, hello.
Hello.
Fancy seeing you here.
Yes. So we're in the advanced repeat class right now.
Yes, I know.
Okay, cool, great. So you're going to talk to us?
No. No, I just thought I'd come say hi.
Hello. This is Dr. Rowland. He is our medical control.
Hello, Dr. Rowan.
Hello. Yeah. Nice to see all of you as well. They said you had something.
Oh, so, yeah, we wanted to ask if when and if our green patches or advanced EMTs can work in the District 2B protocols once they've been made green patch under the direction of a paramedic or.
Yeah. Well, their duties are delineated already.
Mhm.
It's just a matter of, once they're there,
They can start functioning as a green patch.
sure.
You heard it. Sure. Okay.
Sorry, what was it?
The answer is yes.
The answer is sure.
Yes.
Sure. Yep.
It's start functioning.
It's already. If you look at the District 2B protocols the way they're written now, they are delineated with a blue patch or blue line, a green line, and a red line. You are allowed to do anything under the blue line and green line. You can't touch anything under a red line.
Let's get that clear.
Yeah. No red lines.
Green.
Yeah, green only.
Green line, green line.
And that's as soon as we pass our test?
Yep,
Okay.
yes. Soon as you get that patch on your chest, you're good to go. All right? Thank you, Dr. Rowland.
Awesome.
Okay, all right, you heard it there. That easy. That made me happy. All right, cool. You heard him, right? I got witnesses.
I got witnesses.
Yeah.
Sure, whatever.
Yeah. Okay, so let's go back to my epi. So now I'm just gonna pass this to you. And you can throw, this is real epi, so spray it out on the ground, put it back to 0 when you're done, okay? All right, so now I'm just gonna do this real quick. This is not to make you feel embarrassed or whatever, but I'm just gonna go quickly. 10-year-old, go, how much?
3.3.
Okay, throw out 0.3.
Done.
Let me see. All right, cool.
Or no?
No, you went a
No, I
little too
didn't.
much.
Gotta go to the plunger.
Yes, there you go. All right, now you overdosed. Now my heart's
Dead.
pounding.
Oh.
Okay, that's fine though.
Okay.
Great, but that's okay, thanks for being first.
Screwed it up.
Okay? All right, sir. 1-year-old, go.
What's that?
Well, it is the morning.
You should put a 0. I always put 0.1, yeah.
0 point, I'll even do that for you, but that does confuse people, right?
Or
Our dose is 0.1 milligrams per kilogram.
Is there a dance after this?
Okay? Alright, but on that, you have those 0 times 10 would be 0.1. You can do the algebra the way you want to do it. I hate algebra.
So where does it start?
Okay, so now that's good. So, alright, so the plunger, when our plungers start, they always start at 0. So if I did 0.1, I'd do here. Yeah, so 0.2, I'd go here. 0.3, I'd go here. Okay, alright, so, I'll set you up. Alright, okay, 2-year-old, no, I'm sorry, 5-year-old, go. Okay, put it out, let's look. Okay, alright. Alright, now I'm gonna start messing with you a little bit, okay? Everyone got the idea?
I think so.
I don't care, okay, well, alright, and then if we keep having issues with it, we'll go until everyone's got it. So, alright. 3-year-old, yeah, that's messing with it.
Okay, 3-year-old, I'll just go 0.2.
Okay, alright, okay, so that's, now you're practicing medicine. Okay, you are practicing medicine. So you guesstimated that a 3-year-old's gonna be roughly 20 kilograms, and you gave them 0.2. I'm good with that. Alright? Alright. 7-year-old, go.
So I'm gonna bump them up to a 10-year-old and give them 0.3.
Okay, perfect. Okay, so, alright, I'll go back to, 1-year-old, go, oh wait, never mind, lies. 1-year-old, go.
0.1.
Okay, alright. 9-year-old, go. Perfect. Okay, see how easy it is? You can't mess this up now. I mean, I remember spending just hours like burning my mind away, and then all of a sudden I realized I can never give more than 1, 2, or 0.1, 0.2, or 0.3, depending on how old they are. After that, they're an adult, and we give them one whole thing, right? You can't go wrong. All right, cool. So we're going to try another one. Oh, so all right. Now we're going to do a little bit of a race. All right. Well, kind of just to break it up. Okay. Damn it.
I said I brought the
Okay, that's fine.
That one's a lot harder.
It is, that one does suck. Alright, so, back in the olden days, when there was, Gage and DeSoto, right? They would take their drugs, and they'd like, flip the tops off, and just let them go, and then they put it together. Alright, so many of you have never actually put it together, some of you have, some of you haven't. Alright, so, the competition will be between and Alright, now, we're just gonna do 5-year-old, go. Flip it off right, you have to do it like Gage and DeSoto. Alright.
Point two.
Okay, cool. Very nice,
Do
very
you wanna
nice.
verify that I didn't kill him?
Verify. We underdosed it slightly by a hash. That's okay though.
Okay.
Alright. Okay? Okay, cool.
Trenton, did you get it correct?
I got it right, I mean, that way.
Well, if you got it absolutely correct, then you won it. Just like that. I don't know.
Different race.
Yeah, if you did get it absolutely correct, you can, well, I gotta check.
They
Gotta check.
verify, I don't know.
What's your hashtag? Alright. Okay, he was a little bit closer.
Cause you were like neck and neck, so.
Yes, it was.
Okay.
Alright. Okay, so now we're gonna play with our Narcan just for a second. Same thing. I'll just leave that out. Alright, is everyone feeling comfortable with this?
Yep.
Okay. Alright, let's go. If I give it to Heather, the rest of you guys won't win.
That's okay. I expect you have to beat me with it, but that's fine.
Alright, I'm gonna do this. I'm gonna give you that. And I'm gonna give you this.
Alright.
And, alright, we have a narcotic overdose of a 10-year-old. Go. And what is our dose? Anyone can yell it out to help them out.
0.3.
Okay, alright, cool.
I like how he still chucked it, so he looked cool.
Yeah, I'm still chucking it. Let's see.
You gotta screw it in, it's weird.
Screw it in.
Yeah,
Uh,
10-year-old.
I'll go to 0.5, because that makes it easy. Right there. I know it says 0.3, but I just went to 0.5 because that made it real easy.
Is it,
That's why I
isn't our
Correct me if I'm
dose
wrong,
of
but it
Narcan
actually
0.1 milligrams
yeah,
per
it's that
kilogram?
1 milligram per
So that would be
kilogram.
Yeah,
three,
so
but
it's
your
10
max
times the
dose
dose.
is
Also,
two.
so, right, math, too early in the morning.
No, that's
But they
okay.
can get
So
two.
if they're 30 kilograms and the dose is.
So you're three, but your max is two, so you just give them two.
Yeah.
Yeah, so,
up to adult dose.
so I screwed with you on that one, didn't I?
Right.
So our max dose on that is what?
Two.
There's only 2 in here?
Right, there's two.
And?
And they just get all of it.
Yeah, alright, so it's it's not a 0.2, it's 1 milligram.
1 milligram.
No, 0.1 milligram.
0.1
Sorry, it's
milligram
sorry.
per kilogram.
Stop.
And
0.1 milligram per kilogram. I don't wanna screw you up.
Kurt, can I go get your coffee?
No, I've already had my tea, it's
Not a
back there.
0.01, a 0.1.
So 0.1 milligram per kilogram, but our max dose for that
Two.
would be 2. So after 5 years old, what does that tell you with Narcan?
Adult dose.
Give them the whole adult dose, right? Okay,
It was nothing.
alright. So we'll go back to it. Yeah.
I just don't want.
So now you can kind of see that there's a couple little nuances. If you laid out the Abrazo tape, it would say what? 2, right?
Does it say 2 on Narcan? It might actually say 3 on there.
What, for the max?
Well, it can go through. I don't know. Does it?
Says
Yeah, I think it might actually say 3 because I think sometimes we carry Narcan in concentrations of 5 milligrams.
Well, we can look at it.
Says max.
Yeah, what's the Abrazo?
It says 2. Well, the max, so it's 2 to 4, right? Max is 4, but for a pediatric, if you gave him 2 and then gave him a
What's it say in
repeat,
the drug book?
yeah, what does your drug book say?
Two.
Okay,
It says point one and
Two,
two.
but I don't think we
It
have
says
a
2 on the
max
Brazel tape?
dose, do we?
Yeah, it says two on
There
ours.
is a max dose on
Two is the
Rocan?
max dose.
Yeah.
okay,
Two on kids.
we'll go over some more drugs in a minute, but
Adults is what it says,
is that
but I know.
is that frustrating anybody right now?
No.
Everyone good? Okay, alright, so we'll go through all the drugs at this point, this week, and so you kinda have it in your head. And I'll just bring in a drug and say, okay, what's the dose? Alright? And I don't care if you look it up. So for national, as the medics, they make you memorize all the doses, right? And I would like you to know them really well. And if you memorize them, it's even better. But for the national, they've even dumbed it down even a little bit worse. They just say, okay, so you have your book, you pull out your drug and say, I'm going to repeat, this is what I'm giving for this pediatric, this size, this weight, and the partner says, yep, it's this size, this weight, and then they go ahead and do that. They do the 6 patient rights and then give the drug, right? You'll never ever go wrong by repeating it. I love it when, like, I'll say, Cap, can you have me some morphine, or run me up some morphine, and he does, and then he says, here's your morphine, here's your expiration date, and this is how much I gave you. And I repeat back what he gave me, and then I look, and then I give it. So there's no reason to make a mistake if you just do it that way. And there's no harm, no foul. I don't think you're dumb for doing that. I think you'll always give the right dose if you just say it and repeat it to your partner. You know, sometimes if you're the one in charge, sometimes you're just gonna have to repeat it to yourself, right? I had one guy in early on in my career. Narcan came out in these little breakout things, and he pulled out Epi instead of Narcan. And I'm sitting and listening to him in the back of the ambulance, and he goes, all right, 2 milligrams and 1 cc. And I'm like, what's he doing? Okay, 2 milligrams and 1 cc. And, no, well, what this is, 1 milligram and 1 cc, right? He goes, 1 milligram and 1 cc. I'm like, 1 milligram, 1 cc. He was supposed to be giving Narcan, right? And I go back and I go, what did you just do? And he'd give him Epi instead of Narcan, okay? So we had to go tell the doc that he made this huge mistake, and I mean, he did bring the guy back alive. It worked. That's a huge mistake, right? Okay? Okay, all right, so I'm just gonna let you, I'm just gonna pass these around. You guys can, mess with them for a minute and look at the dose.
Medication errors happen.
Yeah, they do. You look at them and try and figure out what's the pediatric dose.
They have.
Yeah, you want these back or should we?
Just we'll pass them around. We'll use them as props
Yeah,
later.
we're gonna save them.
Yeah, yeah.
Alright.
Don't throw them away.
So, bottom line though, when you go into the station on your first day in the morning and do your checkoffs, and you decide you're going to be a patient or practitioner, patient care person that day, right? Go through every single one of your drugs, grab your little book, set it up on your drug box, right? And go through your adult dose and your pediatric dose for 1, 5, and 10. If you do that every time you go on duty, you will never forget, and it'll always stay with you. So every time I'm patient person, I do that. Now, and then other things you can add on to this, you know, you can do your ET size, right? So
3, 4, 5.
3, 4, 5, and your French is 8, 8, 10. French suction. If you have to like suction out of the tube, but there you go. It's that fast. 3, 4, 5, 8, 8, and 10. Actually, it's not 3.
ET?
Yeah, it's 3. Yeah, 3,
Yeah.
3, 4, 5. Okay, there you go. So just kind of look at your kids now. When you walk into the Walmart or walk into the Chuckarama, just look at the kid and then guesstimate. if you really wanna be spot on, and if you're working with a nurse, you better pull out the Brazil tape. And as far as UFA wants to go, they want us to use a Brazil tape, cause it is accurate, and you can't screw it up.
Wow.
Okay, everyone good with that?
That's only half
You guys
an
All right.
just really benefit you to see all your dosages of your cardiac medications together, just in one spot. I like that, but.
We can do that, and then also on your District 2B, there's a sheet on there you can pull down that just has the down and dirty. You look at it, drug doses, so when you go on your District 2B, yeah, it just has a down and dirty adult dose, pediatric dose. And you can't go wrong. I've used that. That thing has not changed for 16, 17 years. So it's the down and dirty.
Like that.
Okay. Okay. Cool. I'm gonna go over respiratory emergencies with Johnny. He's gonna do that.
Why don't we give them like a 5-minute break?
Okay. 5-minute break.
So, pee break.
Pee break.
Okay, maybe 7 minutes. Come back at 9. How's that?
All right. Anyone blown away? Everyone good? Chief.
Yeah, mostly.
I'm always gonna call you council member.
I don't know who you're talking to.
I love messing with you a little bit. You're awesome.
Is anyone logged in on it?
Nope.
You're good. I refuse to stand in front of it.
Oh, we record it too. They
Oh,
can look at it
great.
later on LMS.
Great.
Yeah, you're not out of the woods,
It
Dallas.
is the sound of my voice. I'm recording.
Nothing you can do about it now.
I know, I shouldn't be sitting by this.
I know.
I've eaten 2 things already. And I've got the nerves that I'm just staring at and wanting to eat again.
No one has to say if we did or not, but Prop 2, anyone happy about that? I'm happy about it. So, last week when I went to Tennessee, there was a paramedic who became a doctor, and he just did a large PowerPoint on marijuana and where it affects you at the cellular level.
You're supposed to send that to me last night, and you didn't.
He just barely gave it to me, alright? Is anyone interested in looking at that PowerPoint? It really actually is pretty awesome. He almost
Dad
convinced
wanted
me, he almost convinced me that, you know, that obviously he was not for, but still, his PowerPoint still is very positive on why we should.
It's objective.
I'm against it. But I'm against alcohol too.
Yeah. Alcohol's pure poison.
I'm not against people drinking, but I am a firm believer of not a drop law. If you have a beer, you should not be driving. I don't care.
That's the conflict.
No, it's having had so much carnage from drunk drivers and the social acceptability of it. It's a socially acceptable crime because so many people say, well, I had a couple beers and I wasn't affected. Bullshit. You are affected. I don't care who you are.
You are, especially like that.
And you don't need to be affected very much, but you could say the same thing about cough medicine. You can say the same thing about a lot of things. Good, how do you
Say
know?
freaking cell phone, way
Oh,
more of an effect
I'm-
on your driving than 2 gears.
I'm deaf on
But I
that too.
totally get where you're coming from.
I think if you're texting and driving, that'll lose your license for 30 days, period. Tough, sorry,
Maxwell,
We-
Mayor.
we gotta start being tough on some of this stuff. Cause there's too much of it out there, and it causes too many problems.
Can't be tough on the snowflakes. They'll cry.
Right? No.
So,
And the only thing I have against, marijuana is that there's not a good test for it. In other words, it's not like a breathalyzer test. It's not like with alcohol where they can blow a breathalyzer.
Who was it yesterday was saying that, some med student at a school did come up with a, quantifying urine test with marijuana?
So you're gonna stand out there on the street and have somebody pee in a bottle?
I don't give a shit.
That ain't happening.
Yeah. But some med
Actually,
students
I think if you wanna get high, if you're just drinking to get high, I think marijuana's better for you. Better for your body. Alcohol can cause so many problems in your system.
Yeah, well, supposedly that test, it quantified both alcohol and marijuana, those are the only two it picked up on, it didn't pick up on anything else, but it would give you a, so. I don't know, I've never gotten high, but I might grab my whiskey sours at night.
And that's okay. Fine. Just don't get behind the wheel of the vehicle.
No,
I,
do it so that I can deal with it.
my wife loves it. I'm the DD, so, and my wife drinks. So if we go out to dinner or something, she can have a drink or two, because I drive. But I've told her, you don't have a drink and then get behind the wheel of the vehicle.
My husband drives too, but that's because he says I'm a terrible driver. It's probably pretty accurate. I can't see crap at night. I think I need to go to an eye doctor.
Oh,
It's so bad
Yeah.
now. And it's only at night. I just can't see at night. That's why I hit a deer going 80 miles an hour. But,
yeah.
when was that, back in the last March? Something like that, I can't remember.
I've had a liver too, deafness.
We had articulated very well and tactfully,
Or tell somebody who, family.
But no.
member.
But by the way,
That's really hard to do,
I can see where you're coming from.
really hard. Especially when it's kids.
if
Well,
Sean
then I need
goes,
to find
we
the
get
Mountain City Center,
I'm
so
sure
you know,
still.
that I can walk there. Let's put bars next to all of our churches, and then there would be
So
bars walking
initially that,
distance from
the first
everybody's
issue,
house in
he's
the
like,
state.
you're gonna go
Right.
I try not, I came in.
Problem solved, no
Yep.
more drinking red wine.
Yeah.
Cause I got 13 churches in the city
And
center.
I'm just like, well, and Matt, I got on my truck.
Okay, everybody back?
Myself.
Nope.
We go to one on,
But that was,
Are you thinking or are
and
you
then,
awake?
so I guess it's more drawn in. And it's like, yeah, and then when they call me, it's like, you'll see again, I don't know.
Well, she got her eyes open, but she doesn't want to have it.
that was an interesting choice to start off that way.
Why not?
I'm hoping we'll get more water though.
Huh?
I said I hope we'll end up getting more in the world.
Yeah, but I feel like it's not gonna want to just make it streaming.
But this is super bad because I'm just gonna be parked up with people.
She's got lots of aunts and uncles in here.
Alright, woman.
Take care of her.
Yeah, I gotta go take the little horses, so.
There you go.
So it's all the thing that people do.
Oh, I have Chris back, so.
when does, that position's gonna come out soon, right?
It's gotta be soon.
Oh,
Does
shit.
anyone else have an input?
Let's get going.
The only way you get the silver whip.
Okay, respiratory emergencies. We're primarily, well, we are going to be talking about pediatric respiratory emergencies. Scary. Really scary, kids. Causes a high degree of anxiety for everybody. Usually caregivers, a lot of times us. How many times have you gone on a call and a parent has met you at the door with a very sick child? Fix them. What's wrong with them? Hand you a kid that's not breathing, cyanotic, or severe respiratory distress. What happens to you when that happens?
You go into respiratory distress?
Right, you do. You go into respiratory distress, you get tachycardic, sometimes you'll get diaphoretic. Yeah, scary. So, we're going to talk a little bit about them and some of the things that we can do for them. What do respiratory problems do? They cause hypoxia, hypercarbia. What are some of the signs of hypoxia? Okay, that's kind of a late sign, but it is a sign.
Confusion?
Yeah. Yeah. What's a couple of the very first signs of hypoxia?
Work of breathing.
Yep.
Seen accessory muscle.
Tachypnea. Yeah. Tachycardia. Yeah. Restlessness, anxiety, the kid. We've talked before about the nasal flaring when they're having some mild respiratory distress. Just look at them. They may not look good. They may have that pallor. Like Brandon says, they might have retractions. Cyanosis is a kind of a late sign. Decreased level of consciousness, kind of a late sign. What's another late sign, especially in kids?
Blood pressure drop. BP drop.
Yeah, but looking for another one.
Decrease work of breathing. They
Yeah.
wear out.
Yeah, bradypnea and bradycardia. Their pulse rate starts going down. You have a kid that's in respiratory distress and cyanotic, decreased level of consciousness, and they got a heart rate of 40. Bad. You're in deep kimchi. You are way behind the curve then. That kid's basically respiratory failure, heading to respiratory arrest. So, fix them. Respiratory problems in kids are pretty frequent. Remember when we talked a little bit before about the respiratory system itself? What's the main function of the respiratory system? What does it do? Think about what happens when you,
Exchanges gases.
when you inspire, what happens? Yep, gas exchange, exactly. So when you draw air into your lungs, what's in that air?
Oxygen.
Oxygen. Where does it go?
Into the lung.
Okay,
Alveoli.
right?
Switches with.
And there it's diffused into the bloodstream and delivered out to the tissues. Okay? So, we gotta figure out what's going on. We've gotta recognize these problems right away. Figure out how to take care of them, to prevent them from getting worse. A lot of times, respiratory distress and failure precede respiratory arrest and cardiac arrest. Huge in kids. So one of the first things you have to do with respiratory problems is figure out what the severity is. How bad off are they? In other words, what kind of problems are they having and how are you going to fix it? So respiratory distress. How do we identify respiratory distress? Increased work of breathing, and that results in inadequate gas exchange because they're breathing pretty fast. Okay? What are some of the other signs of respiratory distress? Tachypnea, tachycardia, a little bit of restlessness, a little bit of agitation. So when you're dealing with these kids, think of all the physiological things that are going on in their body when you're dealing with the problem. Sometimes they may have retractions with respiratory distress. A lot of these kids will have abdominal breathing. You'll see the abdomen moving a lot. Have the nasal flaring. Sometimes they might be grunting. You know what that is? Everybody know what the grunting is? How many of you heard that in kids with respiratory distress? Yeah? Okay. Respiratory failure. That's when the body is no longer compensating for what's going on. Compensatory mechanisms have failed. That tachypnea, tachycardia and stuff, that's started to fail. So there's inadequate oxygenation and or inadequate ventilation. A lot of times these kids are really going to be breathing fast initially with respiratory failure. That will be go into bradypnea, where they start slowing down. They've been breathing so fast for so long, they've just gotten tired. And those accessory muscles are not working as well. They're tired, and they don't breathe as well. You might not get any respiratory effort at all. A lot of these kids will be cyanotic when they're in respiratory failure. These kids will really probably be the ones that you'll see the suprasternal retractions on and the intercostal retractions as they're working so hard to breathe. What do you have to do? You got to start fixing these kids. When they're in respiratory failure, you got to be doing something. They require intervention immediately. You have to take care of them. What's the best intervention? Oxygen. Yep. And if you have to, bag valve mask. Breathe for them. These kids are probably going to have a really decreased level of consciousness. You may even be able to get an airway. But it's really important to figure out what's going on and take care of these kids, because failure is going to lead to respiratory arrest. And what's respiratory arrest?
Yeah. Not breathing.
Well, they're not breathing. They may still have a pulse, not for very long, but they may still have a pulse. So you want to breathe for them. Bag valve mask. How many times a minute do you want to breathe for a kid? on kind of just an average.
So the breath every 3 to 5 seconds.
12 to
12 to 20 times a minute for kids. Okay? Or every 3 to 5 seconds. Okay? We're going to talk a little bit about the pediatric triangle, the assessment triangle. Y'all heard about that? Used it? Know what it is? Okay. Yeah. Did you talk about it, Dallas?
Pediatric
Pediatric
assessment
assessment
triangle. It's on the
triangle.
sheet that I gave you guys. If you, I think it's the first one.
Yes, ma'am.
Okay. So, what's the first thing that you notice when you go on a call and you walk in? Appearance, right. Number one, appearance. What do they look like? What does their skin color look like? What do the parents look like, or the caregiver? Are they freaked out, or are they okay? Doesn't always mean anything, because some parents freak out at everything, and parents might not even know how bad off this kid is. So if you go on a call and you go in and that kid is listless and gray and having respiratory distress, yeah, you can tell that before you've even touched them, before you've even really gotten close to them. What about the kid that you walk over and mom hands you the kid and the kid doesn't resist at all, doesn't cry, doesn't do anything? Stranger danger. Most kids don't like strangers, right? If mom or dad hands you the kid and the kid doesn't resist that, probably a problem. Okay. Work of breathing. How easy is that to recognize? Especially with kids, it's actually pretty easy. You can take a look at them and see how well they're breathing. Listen for sounds too, especially stridor in a kid. Stridor is, you usually don't need a stethoscope to identify stridor, right? What's stridor indicative of? Upper airway problem. Yeah, could be an obstruction, could be croup. You don't know. The position that the kid is in is also important. Is the kid, especially if it's an older kid, is the kid sitting up, tripoding, trying to breathe? Retractions, we already talked about grunting and flaring. Especially if they're sitting up and kind of in a sniffing position. Kids have a tendency to sit up and kind of put themselves in a sniffing position when they're in respiratory distress. So if you see that, kid is probably in respiratory distress. And then the third part of the triangle is circulation. How do you figure out circulation and how well their cardiopulmonary system is working? What's a real easy way? Quick.
Capillary recap.
Capillary refill. Yep. What's a good place on kids to do that real quick? Forehead. Really easy. You can just reach over and put your finger right on their forehead. A lot of times with kids, you reach out to grab their hand to check their nail bed. What do? I mean, unless they're in real trouble. They don't want you to touch them. Oh, get away from me. Yep. And you try and grab their hand, they close their fist. So, really easy forehead. If it doesn't work, then lip. You can push on their lip real quick. So, okay. first thing that you're going to assess on these kids is their airway. Make sure that they have a patent airway. Obviously, you can listen. You don't have to have a stethoscope to hear, like I said, stridor or some of the other sounds. Sometimes you can audibly hear them when you walk in. Look at their breathing, see how their work of breathing is. Listen to their lungs. Remember we talked about listening to lung sounds on everybody so you know what normal breath sounds sound like. Get used to that. What else can you do? What's a tool that we have in our kit that we can use for them? Pulse ox. Stick the pulse ox on them. Where can you stick the pulse ox on kids?
Big toe.
Big toes are real good. If you have the clip. If you have the Nelcor, like the neonatal Band-Aid pulse ox, you can put that. You can either put that around a finger. You can even put that on their foot. Put it around the side of their foot. So we kind of talked about stridor and some of the problems with that, and just determine what their O2 sat is. It's a good tool to use. Keep an eye on it. What sats are we looking for? 94 to 99. If they're below 94, what are we going to do? Oxygen. Okay. All right. Then you're going to assess the patient. You got to find out how sick this kid really is. Are they in respiratory distress? Are they in failure? Or are they already in respiratory arrest? Sample history is really good to look at. This is a little bit different up here. Signs and symptoms. What do they look like? What's their breathing look like? Ask mom or dad if they have any allergies. Is this an anaphylactic problem? Did they get into something that they shouldn't have? Or is it a new onset of a problem? What kind of medications are they taking? Mom and dad forget to tell you that they were at the doctor 2 days ago for bronchiolitis, and they put them on an antibiotic and it's not working, and they're getting worse. Or the kid was seen for a respiratory problem. Is it asthma? Do they have a MDI? Past medical history, really, really important. Has this ever happened before? Ask the parent. If it has happened before, what was it? What did they do for it? How did they treat it? How did they take care of it? That can do tons of work for you to find out if they've had it before, and if so, what they did for it and how they took care of it. Last oral intake doesn't mean a lot for us, but it will if we transport this kid and go to the ED. ED always wants to know last oral intake. And events leading up to the incident or the injury. Find out what happened and how long it's been going on. Really important. So, if you're going to give this kid oxygen, how do we deliver oxygen to kids?
They have to be passive.
Low by,
Low
if
by.
they won't. If they have to take
Low
a
by.
Have a parent hold
Yeah.
it.
How easy is it to put a nasal cannula on a kid? Damn near impossible.
Unless they're really, really sick.
Yeah,
Yeah.
yeah. And if they're really, really sick, do they need a nasal cannula? No. No. So when you're going to give oxygen to these kids, you'll probably want to do blow-by. Easiest way, let the caregiver hold the O2 mask up close to them. let the caregiver hold on to them. If they're to the point that they're still just agitated and not cooperating, especially with strangers, let mom or dad hold them. Let somebody that is close to them hold them and calm them down and use the blow-by. How often do you want to check things, recheck things? As often as necessary. Especially with kids, you want to be constantly reassessing them and keeping an eye on that pulse ox. Because kids can decompensate very rapidly. So reassess, reassess, reassess. Also, the other thing that you want to do is you want to find out if you've given them a treatment like, say, albuterol or even blow-by oxygen. Is it working? And if it's not, what are you going to do? You got to have a plan B, right? Or if you've done 2 or 3 albuterol treatments, you're on your way to the hospital or still not getting any better, contact medical control. Call them, find out what's going on. This kid's got a, we've done this and this and this. Kid's still wheezing, retracting. SATs are still 88, can't get him above 90, blah, blah, blah. Call for some help. Excuse me. Speaking of respiratory distress. Okay. Let's do a real quick case study here. 9-year-old or 9-month-old. You respond. Dispatch information is it's a respiratory distress problem. So when you get there, kid's febrile. What are some of the important things that you need to get during your assessment and history?
General appearance.
Yeah, general appearance.
No
What
work
else?
breathing.
Work breathing.
I want to know how high that fever is, because it's different between a little increase and a big increase.
Right? Yeah. What is the temperature? How long has it been like that? Have mom and dad taken it? Do they know what the temperature was, say, yesterday or even an hour ago? How long has this been going on? We kind of talked about this already. Has it happened before? What medications are they taking? Another question to ask them is, are they supposed to be taking any medications that they're not taking or that they haven't been taking? That's pretty important too. The fever is really important. Get information on that fever, how long they've had it, and what's it been doing, and have they done anything? Have they given them ibuprofen, or have they given them liquid Tylenol or something for the fever? And when did they give it to them? If it's an injury, what happened? How long ago? Have they been seen for it? Have they been treated for it at all? We talked about the appearance, work of breathing, abnormal color for the pediatric assessment triangle. This is really good to use. It's not only good for kids, you can use this on anybody. You can use this on adults too, not just for kids. Check their airway, respiratory rate. What's their chest look like when it's moving? Is it asymmetrical? Is one side different than the other? Are they retracting? Breath sounds, O2 sat. So this kid, when you walk in, you're just kind of sitting up, looking around, crying, got red eyes. He's got some retractions, got some nasal flaring, and skin color is normal. Capillary refill is pretty normal. So, what do you think? How sick do you think this kid is? Not sick?
Normal skin if he's crying.
I mean, mildly
Is
sick.
that
Okay. Okay, all right. So, you start doing the rest of the assessment. He's breathing 80 times a minute. He's got a SAT of 90 and a heart rate of 180.
He's working hard.
He's working pretty hard, isn't he? Okay. So, does that change how you might look at this kid? Okay, now what do you think?
He's compensating, but he's gonna decompensate.
Exactly. This kid's in moderate to even maybe severe distress. But he's in respiratory distress. Okay? He's not failure, but he's in moderate to severe respiratory distress. What do we want to do? Okay? Oxygen? Yep. We want to find out for sure if he's got an airway problem. So listen for stridor. When you're listening to lung sounds, when you hear wheezing, what's wheezing indicative of? Lower airway problem, usually asthma. If you hear crackles in the lower airway, that could be either like pneumonia, or it could even be some kind of disease that the kid has, congenital problems. So, what are some of the common lower airway diseases? Asthma? Asthma is probably the most common one.
Cystic fibrosis.
Bronchiolitis.
Bronchiolitis, yep, okay.
Would cystic fibrosis appear that way with the mucus in the lungs?
They usually don't have abnormal sounds as much as they have excess fluid and stuff in their lungs. So, another lower airway obstruction problem. Now think about the airway and the anatomy, but it could even be a foreign body obstruction or an obstruction of some type in the trachea or in the bronchi. So we kind of talked about it: asthma, foreign body, bronchiolitis. Anybody ever had a kid that's had bronchiolitis? They get pretty sick. It's kind of scary when they have bronchiolitis. They really are working hard to breathe. SATs are usually in the toilet. Causes a lot of problems. Okay, so this kid has a history of fever. It's been wheezing over the last couple of days. You suspect a lower airway obstruction. So we've already talked about what we're going to do and how you're going to transport this kid. You going to let mom and dad take him to the hospital? Okay. You're not going to release, are you? You're going to transport this kid low by O2, reassess, reassess, reassess. Constantly reassess. Probably the most important thing that you can do. Could try some albuterol for the wheezing, especially to get those lower airways opened up a little bit. But yeah, you need to get this kid to the hospital. Get him taken care of. Position of comfort is probably one of the most important things that you can do for them. Just so that they're not agitated. talked about albuterol. We don't, AEMTs can't do nebulized epi, can they, Kurt?
Actually, yeah, you can.
Can they?
Yeah,
Okay.
there's a lot you can do, especially with the new protocol out, so.
Okay.
But yes.
2 milligrams and 3 cc's of normal
It's,
saline.
and here's the firefighter easy way of memorizing this. Easy is 1, 2, 3. That'd be 1 to 1, 2 milligrams, 3 cc's. That's how I do it. Yep. It's easy as 1, 2, 3.
I like that.
See, you were
1, 2, 3.
1, 2, 3.
Neato.
Yeah. There you go.
Okay, how are we gonna distinguish between the respiratory distress and respiratory failure? Especially with this kid. What's gonna happen as he gets sicker and sicker? Or she.
Accessory muscles get tired.
Gonna get tired, yep, gonna get really tired. Decreased level of consciousness. SATs may deteriorate. So, gotta really keep an eye on him. Because he's not in respiratory failure yet, but can get there. So, respiratory failure, it's got an abnormal appearance. Respiratory rate is going to be all over the place. Could be really tachypnic. If they're bradypnic, what's that indicative of?
Start to crash.
Yeah, they're getting close to respiratory arrest. So you've got to aggressively treat it. Probably going to have to bag the kid. Tachycardia initially will go to bradycardia. When they're bradycardic, they're in really severe distress. So you transport him with low by O2, give him some nebulized albuterol, and he gets better on the way to the hospital. Bazinga. There you
Saved it.
Yeah. Okay. So kids, we already kind of talked about this before. High degree of foreign body aspiration. Mostly because what little kids do when they get a hold of something, where does it go? Right to the mouth. Yep. Okay. So if they, does it always cause a complete obstruction? No. No, doesn't always cause a complete obstruction. If they have a partial obstruction, what are you going to hear? Stridor. Yep. And they'll be having difficulty breathing. And depending on how much of an obstruction there is, it can either be high degree of work of breathing, and their SATs could start deteriorating, or it could just be uncomfortable for them. What if it doesn't go in the trachea? What if it goes in the esophagus and becomes an obstruction? Can that still be a problem? Yeah, because especially if it's in the upper thoracic region, it can push on that trachea. And think about kids' anatomies. Do they have a big trachea? No. Nope. And if they've got an obstruction in their esophagus, it pushes on that trachea, they can still have the same signs and symptoms. So look at them and properly assess them. What if they have a foreign body obstruction? What do?
Back
Okay. Back blows. For infants especially. If it's an older kid, you can try back blows, but older kids probably aren't going to respond to back blows as well. I had to do this to my oldest daughter when she was about, 7 months old, I think. Her grandmother gave her carrots at Thanksgiving. And she got a complete obstruction. And back blows work. I can tell you they work.
So, not in the throat, but I had a kid that would always stick things up his nose.
Oh, yeah.
Constantly.
Yep.
So, even though it's not as life-threatening, you can still get one. So, here's what I was taught when I went into Instacare one time. Kid has something in their nose, have them lay down, have the parent put their mouth over like you're gonna do mouth to mouth, hold the nostril closed, it's not
Yeah.
affected, and blow.
Blow.
And it'll shoot out. And I did that so many times with that kid, and he laughs. I mean, he would just giggle. He thought it
Yeah.
was so funny, but it doesn't turn
Rock
on.
Right?
stuff out his
Save him
nose.
to the hospital, so that
Yeah.
My nephew purposely puts stuff in his
Yes.
nose because he thinks it's funny.
yeah, exactly. So there you go.
It's real gross.
Yeah.
Yep. Yeah. Kids are famous for that.
But that could just save a trip to the hospital, so there you go.
So if the back blows don't work, go to chest stress. I'm sure Dallas has already talked to you all about it. If you can see something inside the mouth, get it out. If not, you might have to do compressions on them. For kids, you can do the Heimlich maneuver. That might be kind of hard sometimes with the kids, but sometimes you got to do what you got to do. And if they become unresponsive, start compressions on them. So you get dispatched to a 4-year-old with respiratory distress. Mom states he was playing with a small Super Ball before he collapsed. You don't see the Super Ball around. Kid's unresponsive, poor muscle tone. He's got striders, severe retractions, and he's pale. What do you think?
Wow.
Okay. Is he in severe distress?
Yes.
Yep. At the very least, he's probably in respiratory failure because of the appearance, the stridor, severe retractions. Is he getting any air? Yeah, maybe not. Trying to. That's why he's got severe retractions. Poor skin color. So, got an obstructed airway. He's breathing 12 times a minute, but he's got decreased breath sounds, little or no chest rise, heart rate's 100, and dropping. But that's significant enough.
Going into respiratory arrest.
Yeah, he's decompensating now. Yeah, he's in trouble. So we kind of talked about how sick he is. He's pretty sick. And what's the problem? Airway obstruction. So what are you going to do about it? It's a 4-year-old.
Was he unconscious on the ground?
Unresponsive.
Unresponsive.
Yeah.
Do you open his mouth to see anything?
Don't see anything.
He's on it all the back blows.
And you could try back blows. Probably going to have to go to Heimlich on this kid. He's 4 years old. Yeah. Do the Heimlich.
But if he's unresponsive, right?
Yeah,
You
so
can't
that's
do the
what I'm saying,
Heimlich,
is
so
he
you're gonna have to
standing or
start
laying on the ground?
CPR and then
Yep.
to you get like a McGill's forceps or something, try and see if you can see an obstruction afterwards.
Okay. Try and breathe for him. See if you can breathe past the obstruction. If you can't. I've told all you guys my nightmare one about the 12-year-old girl.
Power at balloon.
Yeah. Yeah. So with this kid, if you can't get that obstruction out. ALS is probably gonna have to do a laryngoscopy and see if they can figure out where that obstruction is and if they can get it out. But what is it? What's the obstruction?
Super ball.
Super ball. So what's its shape?
Round.
Round. Where is it?
Down.
Yeah, it's down in the, at least the laryngeal area, maybe a little bit deeper. And is that nice and dry down there? Oh, hell no. That's wet. You think you're gonna be able to get a hold of this super ball with a set of McGills? It's gonna be really, really difficult. You can try, but yeah, gonna be really difficult.
They did it.
But you've got a super medic on scene who grabs a hold of that and pulls it out. And within you do a few ventilations on this kid for a minute or two, so he's breathing on his own. By the time you arrive at the ED, he's sitting up, talking. Yeah. Okay. One other thing I want to talk to you real quick about is disordered control of breathing. It's in your book, you talk about it. Disordered control of breathing usually is a result of some kind of problem like some kind of CNS problem. Usually either seizures or traumatic brain injury or some kind of problem in the brain. Usually when you get called on that, the chief complaint will be the parents will say he's breathing funny. They'll have erratic breathing patterns, almost Shane Stokes type breathing. The biggest problem is just identifying why they have this problem. Like I said, it's usually from a neurological disorder of some kind. So just be aware of it. A lot of times they'll have shallow respirations and they're going to be irregular and they're usually going to get hypoxic. And they can become apneic from it. So be aware of it. Okay. So what do we use to determine how sick they are? Pediatric assessment triangle, right? Find out what's going on. Remember, look at their appearance. What position are they in? Are they in a position of comfort, or are they in a position of obvious distress? Look at their breathing. See how well they're breathing. Are they tachypnic? Are they bradypnic? They using accessory muscles? They have any nasal flaring? Are there any sounds? Are they grunting? Is there any stridor? Anything obvious? And look at their skin for circulation. Are they pale? Are they cyanotic? What's going on with them? Remember to just always check for airway and breathing. Always, always, always. Okay. If you're working on a kid and you can't get him any better, who are you going to call?
Ghostbusters.
ALS.
ALS, right? Yeah.
Yeah.
Yep. I was waiting for it. I knew somebody would do it. So with the way our department is heading, you're probably not going to have to call for ALS. You're probably going to have an ALS partner with you. So I can't emphasize enough to reassess, reassess, reassess. Constantly reassess. Especially these really sick kids. Or a kid that's in moderate to severe respiratory distress. Keep reassessing them. Because kids will decompensate really quickly, and they'll go into failure pretty quickly. Once they're in failure, you're really in trouble, and they're heading towards respiratory arrest, and you don't want that. Any questions? Anything about respiratory distress or kids or? Okay. That's the down and dirty, kind of quick overview, respiratory emergencies with kids. There's probably about 60 pages in your book on respiratory arrest and what you can, or respiratory problems and what you can do for them. Some of the real common ones, especially, we're getting into the time of year for RSV. Going to start seeing RSV in kids. Severe respiratory distress, abnormal lung sounds. Going to need to give them O2 and get them to the ED. Probably be taken them to Primary Children's Hospital. So RSV starts in early December, gets really bad in January and February, and then by March it starts easing off. But the next 3 or 4 months, a lot of kids with RSV, especially kids with predisposing problems, kids with asthma, or kids that have had bronchiolitis and stuff. So just be aware of that. Okay? Bitching. Okay.
Ready?
Should we give him a break?
Yeah, so put 5 minutes, 5 minutes.
Okay.
Yes. Well, let's just leave that one safe.
Do you need the overhead, Kurt?
Yeah.
Okay. I'll just leave it on.
So I can do clinical operation guidelines. Let's just say we're just doing respiratory distress.
That's the respiratory part of the test now.
Click on that. Oh.
I always put in that disorder control thing because it's usually.
Oh, okay. So this basically, all providers will do this, green and blue patches will do this, you can do that.
It comes in kind of weird.
And
It's
it's the
usually
same.
seizure, kind of problems like that.
Okay, so you want to go back. Meds, oh, okay, so you're, so right here.
I had their own last year.
It doesn't say what you can do, the only thing you can't do is you can do all the rest of the shit. I don't think we have,
Dr. Roman exemptions.
yeah, so that and right now ketamine is not an advanced.
But that's not.
It's not even like 106 now.
Okay, then I won't worry about
Okay.
it. Where is it?
No, it's just OBG like that.
Well, you are golden.
One of them I read.
Makes sense.
That's nice, the code bunch of pages, I'm just not printing them all. What do you guys do for Thanksgiving?
Station.
So I rented that car. And last week in Tennessee, I got it to 105.
I was like, what's pretty fast?
It's 2019. Except every time I parked, I was afraid someone was gonna like ding it. But yeah, it's fine. It was a good one.
Did you have the top down when you went 105?
They should be saying that is.
So yes, and so we did like a full-on drive out to where it's like about 80 miles to where they make Jack Daniels, and we went the slow way. And
Was it so slow?
no, I mean you can see the leaves are changing, and
Yeah.
it's pretty awesome.
Get a Lynchburg Fire Brigade patch.
No,
They've got some kitchen engines. Going out there? I'm gonna go to Kelly.
and then so my wife, she walks over and sits on the hood. I'm like,
Don't have one.
what are you doing?
I didn't get the insurance.
So what are you doing?
Be careful.
On a flat?
Yeah, but it was good. It was really good.
Oh, really?
Yeah. But it's only one. That was not okay.
I think by the time I get to that point, I'll be kind of over it. Yeah.
Tell them how fast you went.
No, I got to 105. That's
You
good.
tell them you didn't even think to set it as your background until I mentioned it?
Yeah, she did. She's like, why don't you set that as your background? I'm like, okay, I will.
Yeah, so you were just showing, I was like, why is it on your background? And I can take a picture of it and keep making.
Yeah, see, this is what I got.
Did it top out at 105 or did you just run on a
No,
road?
it tops out at 200.
Did you just run on a road then?
I did. And it has like this little feature in there that it'll see how many G's you can pull. And so I'd stop at the bottom of the on-ramp, and then I'd just pound it. I got it to 1 G. It's pretty, oh my gosh, it's pretty awesome. I think this will be the last year though that they put a front engine in them. Next year, 2020, they're gonna do a rear mount engine. Cause they've been screaming for it since 1953. But they're gonna, the guy who,
I don't like the convertibles though.
yeah,
They're slower.
No,
they wanna be European style. But that thing like just handles perfectly. Alright, why is that? Okay, cool.
Yes, they are.
I mean, compared to some of the others that are all looking to it.
I'm gonna be good enough just to get me like a 1978.
Yeah.
Yeah.
I almost bought like an 88, 89. Guy was selling one for like $3 grand.
Mm-hmm.
It was in decent shape. The only thing was this. I asked him if I could drive it. He's like, well, it's almost out of gas. And so I was like, yeah, that's a little sketchy, but
I'll bring gas as we should say.
yeah. So.
I had like a GT Mustang, and it was pretty fast. Drove it for a couple of years, but it just, man, they are not good in the winter. They're horrible. And if you get even like frost on the road and you pound down on it, your ass end just goes. And so I was coming home from off duty, and I was driving southbound on I-15, and I saw Sandy. They were on some call, right? And I just looked over, and it had been snowing really bad. And I looked over, and I'm like, Sandy, you know, just goes in my head, right? And then all of a sudden I hit this patch, and I did a full 360, and then righted myself, only out of luck, right? And I'm like, well, I like, you know, kind of, I'm a badass. I mean, but
Pull off the freeway.
I hate that car in the snow.
Yeah.
They're not snow cars at all. So I don't know. It's
I like
not very
Corvettes a
practical.
lot more.
Yeah, not very practical at all. That was just fun. We just treated ourselves on that because it was kind of fun. Yeah. All right, everyone back. Cool. All right, so So we're gonna talk about some rhythm disturbances, what we're gonna do to treat it, right? And, okay, so, this is a fast or slow heart rate? Okay. All right, so what do we wanna call that one? All right, yeah, you could call that, so, well, okay, so, let's go back to my divorce story, right? Is she on the same page as him?
Yes, that's the second or something.
So, and he's on his own thing, so that's a third degree. Yeah,
Yep.
so that is a pretty long one, so the other one is, so I'd say if I'm kinda doing this, he's buried in here.
Yep.
So she's working graves, he's doing his 4896, they're in a full third degree block, right? Okay, so, but let's go back to our pediatrics, because like I said, I love like Chevy trucks, right? Big Chevy trucks, I do. And I have two of them. I have like an old 76 Chevrolet pickup truck, and I have a newer Chevy pickup truck, and they're both 2500s. And like I said, getting into a new truck and smelling a new truck is equal to a woman holding a brand new baby and smelling baby powder, right? Okay, so that's how I equate them. But here's the thing: my old '76 Chevrolet pickup truck. Briefly, I may have already told you the story already. '76 Chevrolet pickup truck. I have to go out. I have to pump it 25 times, try to start it, pump it another 25 times, try to start it, and maybe the third time it'll start. But then I have a carburetor in it, and it takes a few minutes to warm up. But once it warms up, it has a 350 motor. It only has 80,000 miles on that truck, and in its day it was pretty badass, and even today it's still badass, but very rusty. Okay. My new truck, I walk out there, I turn it on, and literally I can almost throw G's in that truck getting on the highway too. I don't have to wait for it to warm up. So pediatrics are like brand new trucks. Okay, they're brand new, and they shouldn't have a block. All right, I'm showing you a slow heart rate, but a slow heart rate for a pediatric usually is because of what Johnny was talking about. Probably a respiratory problem at first, right? So a slow heart rate in a pediatric is danger, danger, danger. Okay, that means that they've compensated enough, they can't compensate anymore. So if you get to a kid and they're blue and then you have a heart rate of 40, you know that this is now time for you to get to work, right? So be careful with that one. So slow heart rate, pediatric, danger. All right, so here's another slower heart rate. But again, this one does it look like that she's doing her thing? Okay, so I'm going to still call that probably a third degree block too. Okay, now oops. So that's a slow heart rate. But again, blocks aren't what we're going to see on pediatrics. So I'm just trying to show you some slow heart rates. Okay, so we'll talk about, well, what will you do for a slow heart rate for a pediatric in a minute? Okay, all right, what's that? VFib. Okay, we know what we're going to have to do for that. All right, so if this is a 6-second strip, I can just look at that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So about 110 for pediatric, normal or not?
How old are they?
We'll just do 1, 5, or 10. Well, okay, between 1 and 5. Is that out of normal for a 1 to 5 year old? Not even at all. Okay. Okay. All right. Ooh. Okay. Now this is fast, but there's something wrong here. This is wide. Okay. And I can't tell you how I memorized that, but wide is bad. Bad girls are wide. Okay. That's how I always say that. Okay. You can put that in your mind however you want to. So this means you have a sick ventricle. So your ventricle is sick. Okay. pediatrics, do they have broken down 1976 Chevrolet pickup truck broken ventricles? Not really. So you probably won't see wide, but there is an algorithm for that, right? So what do I do if I, you know, you're gonna treat them a little bit different, just in case. If it is wide and it has a bad ventricle, it's because they're born that way, right? Okay, so don't worry about that one too much, but that is a fast heart rate, okay? All right, so we got 1, 2, 3, 4, 5, 50. Okay, so this is where pediatrics are slightly different. So if a pediatric's heart rate is under 60, what do we start doing? CPR. Okay, it's the only weird nuance that we need to know. That we're gonna, you know, we do actual CPR and a beating heart, right? And we do it on purpose, right? So what if it's 62? Yes. If they're blue, listless, not looking too good.
Yes.
Yeah. So this is where you've heard the medics yell at people, treat the patient, not the monitor before, right? Well, this is where you're going to have to start thinking through that too. So if they look sick and they have a really slow heart rate, we're going to get after it, okay? All right. Okay, this is another fast and narrow. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 190. Bad? Yeah, and the only reason why is it's going so fast, it's not bringing in something and it's not putting out something. It's going so fast, you're not getting good cardiac input or output. And so that's why it's bad, okay? So we want to try and slow that down. But can green patches use adenosine to do a Windows reboot mechanically?
No.
Drug-wise? Can we do it mechanically by using synchronized cardioversion? No, so you can't do that. So at this point, supportive care, ALS coming in, and because you're not gonna, again, not medical, but this is the way I think about it. It's just like that Windows reboot, right? I can do it with the drug, or I can do it by switching off and switching it back on and hitting it with the power, right? So that's what your thought process is on this one. So usually for a pediatric, the magic number is 180. Anything over 180. And 220 for a newborn?
205.
205?
That's what I've got on my thing.
Okay, all right. So a newborn could,
Up to 3 months.
yeah, up to 3 months. So a neonate, right? So just kind of keep those in mind. It's in your book. If you're ever asked about that, that was one you might need to come up with the right numbers. And whatever the book says, this book is the right answer. Because sometimes our textbook will be off a little bit. Okay. Okay. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 90. Looks pretty normal. What do you want to do with this? Just treat the underlying cause if you got called to this guy, right? That's a normal heart rate. No one's going to have any issues with that. So that looks normal. Okay, so non-EMT drug, adenosine. Now, here he is. Anything that kills, 0.1, right? Because essentially you're stopping the heart for like 3 seconds, right? And our indication for that is SVT. And then for that one, you double the dose after that, 0.2 milligrams per kilogram, IV bolus. Okay, so I'm going to even tell you, most of primaries and those guys, if I were to do adenosine on a pediatric, they would be just beside themselves when I walk into primary children's. Okay? So a couple things we can do. Just make sure you do your supportive care. Airway, breathing, circulation. If you have an IV set up, and we'll talk about IVs and IOs here in a minute, you have an IV, IO set up, you're gonna do that supportive care, but then maybe what is our dose for, just a fluid bolus per kilogram, right? 20 milligrams per kilogram. So, quick, 5-year-old. So total of 400. Everyone good with that one? So, but one time. Don't reassess, see what's going on after that. But I would take care of whether the oxidation, airway breathing circulation. Think about a fluid bolus at first. That may put their heart right. They may be beating their heart so fast because they're dehydrated, or they're sick, or they're septic. Go ahead.
One of the primary docs told me when I brought in a baby, it was like a, I don't know, 9-month-old SVT. Their first line thing that they'll do for SVT is actually have them either take a pacifier or a bottle or nurse, because I guess the suckling as well will work like a vagal kind of effect and actually convert them. So you can also try that with SVT before the drugs as one or BLS. Is that's how you vagal with a baby, is you have a nurse or suckle or and you probably would want to do a bottle.
It's not in our protocol, but you know what? Why not do that with moms? I always bring mom along in that situation, right? So you're in the back of the ambulance, she's got some privacy. Go ahead, right?
The other
But-
thing that the book said was that it had a recommendation to take a cold pack, be very careful, but put it just on the top part, not pushing it down on their eyes, but that will cause them to clench and bear down.
Okay.
And
And what vein, sorry, I gave it away already. What response were we looking for? Vagal response, sorry, okay. Alright, cool. Alright, so, albuterol, well, I'm gonna flip around here. So, no, I guess I won't. I'll just, so this adenosine is to slow down the heart, Windows reboot, okay? Usually narrow, QRS, very narrow, not wide. Go.
I was gonna say, is that like adult, is there stable SVT before the adenosine if unstable cardiovert? I know we don't do it. But
Yes. So
Same with
someone
pain
who's
and
sick,
thing.
so we'll say sick or not sick.
Right.
Someone's sick, get right after electricity. Someone who's not really sick, but still, you know, they're saying I feel heart palpitations, whatever. Do the vagal maneuvers, and then the adenosine, then or first off, remove the probable cause. Okay. All right. Okay, so albuterol. So this is a breathing problem, and it's indicated for asthma, anaphylaxis, hyperkalemia, because it messes with your potassium, right? So our dose on that is 2.5 milligrams if under 20 kilograms, and 5 milligrams if over 20 kilograms. Okay. So 5-year-old. That's wrong.
Yeah.
That's wrong,
Isn't it 2.5?
cause it's 1.5
It's one. I
if
need
they're
to
under
change that.
20, and it's 2.5 for peds, cause 2.5 is our adult dose.
Yeah, 2.5 is the max dose.
Well, we can give it a second time, maybe with medical control on peds, but.
That slide's gone. It's 2.5.
Yeah, the 2B protocol.
You don't.
2.5
That's it.
milligrams
There's
and 3
one
milliliters.
half of it, so there's like 1.25
If they're over 1
Like
year
even
old.
then, I mean.
And what is it for a pediatric for under one?
It's not the same
I'm
then.
just gonna squeeze a little bit.
All right.
Just think about, well, you can
But
squeeze
we
half
don't
of
give
it
it to infants.
Yeah.
under
we give
one,
up
but if they're
infant.
over a month, you can.
Hold on, I'm taking that one out.
Under 1-year-old dose.
But we don't give it to infants under 1 year old.
I'll double check, but that's in our protocol.
Medication is on the website, just has the 2.5 for
Yeah, it's just on
over
ours,
1 year.
2.5, but that
Oh,
doesn't say anything about age.
Let's see. All right, sorry about that, guys. I've got it fixed. All right, so amiodarone. Okay, so amiodarone would be in a full arrest situation, right? Whether we're going to give it for SVT, VTAC with a pulse, VFib, pulses, VTAC. For us, for advanced EMTs, we won't give it for SVT. I mean, you can, it's part of the algorithm, but for amiodarone, you're always going to use it for VFib and pulsus VTAC, always. The other two, now you're riding a tightrope, right? Because you gotta make sure what you're doing on those ones, okay?
So it's the same for pediatric patients under 1 year, 2.5.
2.5 for the algorithm.
It just says after nasal suctioning.
Okay. Sorry about that, guys. I pulled this off an old slide and I had to fix that. Yeah. So amiodarone. Now there's several drugs that have the 5 or a 0.5, and amiodarone. So we're gonna pass this out. Okay, amiodarone for you.
Sweet.
One for you. Okay, and one for. Oh no, we'll switch it around. We'll give it to you. Okay, so 5-year-olds go. How much? If we're gonna have a pediatric
5?
5-year-old. What's the dose?
40? No.
2 times 5 is 10. Add a 0, right?
100, yeah.
Okay. No. Okay. So that's the thing. It messes with your brain, right? So because you're adding zeros and whatever. That's why the Brazil tape is actually nice. But I've already memorized to do the 0. All right. Cap. We got 10-year-old. Go.
10-year-old, 5 milligrams, so 150.
Okay. So in one of these, how much is in one of these?
150.
So 10-year-old. So we can't go wrong on this on a pediatric. We're only going to use 1 vial on them, or we're going to use 100, right? Okay. So, Chief.
Yeah.
1-year-old.
50 milligrams.
Okay. All right. So on an adult, this messes people up, right? Because they go and grab a 3cc syringe, and you really need a 5cc syringe, really. And we don't really carry a lot of 5cc syringes, so we usually put it at 10. So this one, just be careful when you decide you're going to do your amiodarone. Then make sure that you at least use a 3cc syringe. Okay. Okay. So when in our algorithm do we do that? Okay. So let's just go ahead. We have VFib or pulses VTAC. We have started CPR. We have shocked them. We've given an epi. Now, when do we use the amiodarone?
After a second show.
Yeah, and that's fine. You can do it right after. Sometimes you're really fast, and you may be able to do it in the 2 minutes 5 cycles. But I love the 2 minutes 5 cycles because that to me is organizing all the chaos. Do everything in your 2 minutes 5 cycles. It's just easy way to organize. So this would be our second line drug. I could even call it my third line drug because electricity would be my first, the first line drug, epi second line drug, or first line drug, wherever you decide to go first, right? But this would be my third drug that I would give in that. Okay, everyone good with that one? And for pediatric, how many milligrams? 5 milligrams, okay?
Per kilogram.
Per kilogram. 5 milligrams per kilogram. Okay, let's look at atropine. Okay, so atropine, this one is, do you want to grab some atropine? Or,
Oh, sorry, I only grabbed the one.
No, it's okay. That's all right. I'll come back to atropine, and I'll pull one out because I want everyone to see that one too. Okay. All right. The only reason why I'm going to give atropine is to increase heart rate, right? Or to slow it down. But we don't do a lot of pediatric. We don't use a lot of, so for adults we use atropine to slow down the heart. Okay. For pediatrics, for bradycardia, I'm sorry, let me back up again. If you have a slow heart rate, I give atropine to kick it up. So we have our SA node and our AV node. And I look at them like gas pedals, right? So epi is your SA node. So I put on the gas and I let off my AV, all right? The other way around is I push on the SA node and I let off the AV. Another layer of that is sympathetic system and parasympathetic system. So if I give epi, that is in my what system? Parasympathetic system. So I put the gas pedal on the parasympathetic system, which kicks SA hard, okay? And then if I use atropine, it works on the parasympathetic system. So it lets off the gas pedal on SA, then pushes on AV, okay? Is that confusing? Okay, so I'm messing with my systems and trying to increase heart rate, okay?
Okay, I got, atropine is like your emergency brake. So you're pressing gas with your epi,
Yep.
and that's making you go. If you wanna go faster, you're gonna do atropine and let your emergency brake off.
Yes.
For your parasympathetic.
I like that. That's good. I like that. Yeah, that's
Atropine works primarily on the AV.
yeah, and it works at the AV node, right?
Yeah.
So and AV is controlled by the parasympathetic.
Cause
Right.
it blocks that, takes away that
Mm-hmm.
body's response to trying to slow things down.
Yep. So, okay, the second reason why we'd use it is for organophosphate poisoning. Doesn't happen very much. You guys it got burned in your brains during the Olympics. We have a ton out in like orchards and stuff. There is organophosphates out there, but we literally do not have enough on our ambulances to even take care of our own, right? Unless we have this. Yeah, if you have hazmat there, we don't have enough. So you're gonna have to throw up and drool and be really sick for a while until someone gets there.
Till a Friday night.
Yeah. Okay. All right. So I'm not gonna make you memorize the organophosphate poisoning dose. Just be aware of it. But again, here's the problem. Okay, so we talked about respiratory distress, right? And a kid is been kicking his own ass for a while, right? And I'm sorry for swearing, but I just can't help it, okay? Ass is in the Bible, right? So we can say. So he has burnt his heart as hard as he can. He has used every muscle. He or she has used every single muscle they can to breathe. We get on there, and his heart rate now is at 40. And so we say, and I'm just telling you, use caution in this. Now I'm going to use a drug that increases oxygen consumption and kicks the living crap out of the heart. Okay? Out of already a tired out kid. So, is this an invasive drug? So I would always reach for epi first before I do atropine. Just because it is very, very invasive. And so with the kid that's already just about ready to go out, I am kicking him up. I know what all your causes are before you kick this one in. So airway, breathing, circulation, try to bring up everything you can. And then if you can't, and maybe they're septic, that'd be a time where I'd think, okay, they're septic, or in other words, they've got an infection in their blood and it's going down, and they're not having problems with breathing, but their heart rate is not coming up. Then I would like my atropine.
Epi's first anyway.
Yeah. Epi goes first, atropine second.
For the peds, Epi's first on every cardiac.
Yeah, and in fact, another thing, it's easy as 1, 2, 3. Pediatrics, it's always about epi. Always about epi. Just put that in your head. Almost everything's about epi. Okay? Okay, so everyone good with that one? Okay, so with okay, so let's take a look at our atropine. So this comes just like our epinephrine, right?
Mm-hmm.
So we have 1 milligram, and it's 0.1 per hashtag, right? Okay, or we have 1 milligram in there, right? Everyone good with that?
Yep.
Okay, so Now this one kind of messes you up, and I don't like the math on this one. Well, you can, right? All right, so 2 times 10 is what? 0.2, right? So I'm going to have to give 2 hashtags. 2 times 2 is 4. I'm going to have to give 0.4. So 4 hashtags. 2 times 3 is 6. So 0.6. But there's a max dose here. You got to remember, there's a max dose. 4. You're not allowed to give more than 0.4, right? What? Go ahead. Not allowed to. Go ahead. Hit me. 0.5. There you go. That's the max
That's our
dose.
adult dose, we can't see.
Yeah, you can't give more than 0.5, half milligram, right? So you can't give more than that. So if I give 0.6, have I overdosed them then? So you got to remember that the max dose you can give is 0.5.
This is saying 0.3 to 0.4 for peds.
Yeah. So in our District 2B protocols say they don't want you to go over 0.4, right?
For the peds,
Yeah.
And then adults 0.5.
Yeah.
Right, per dose when you're
Mhm.
Yeah, so the drug cards.
What does 2B and what does my drug card say? So there's going to be a little bit of a difference.
He's got max dose 3 milligrams. Is that supposed to be a point?
That's over.
That's every, okay.
Yeah. That's over time. Like you've done it and done it.
Over the.
Yeah.
Oh, I guess
Yeah.
this is 0.4 milligrams per kilogram is max dose.
Yep. Okay, so again, atropine's gonna be tricky, right? Number one, it is kicking your heart, it increases oxygen consumption. The dose is just a little bit different than all the ones that we know of right now.
Just take your epi-dose and double it.
Yeah, and you can do that too. But again, at 0.4, so 2 times 2 is 4, that's your max dose. If I'm giving 0.6, then I'm overdosing them. I'm giving them an adult dose plus a 0.1. Alright, so if you decide you're going to go, if anything over 5-year-old, well, how about this? Under 10 years old, always only go 0.4. 0.4 and 0.2. So you're going to go hashtag, 2 hashtags, I'm sorry, you're going to go 2 hashtags or 4 hashtags, done. Okay, so hopefully that helps you. I'm not confusing you, and it helps you. But an adult, we go half that whole thing, right? We don't care about adult right now. We're going to talk about peds still. Okay.
So Kurt,
Yes.
I've never given a pediatric atropine dose. Ever.
So, okay, there was another thing they used to do. If they were going to intubate a pediatric, they would give them some adenosine real quick. No, sorry, atropine. Shit, I'm losing it. They would give them the atropine to kick the heart up because in the when your bronchioles, when you tap on the carina, it lowers the vagal stimulation lowers their heart rate. Did you ever do that?
No.
No, because some of the first time I saw it was it must have been a
anesthesia induction,
yeah.
and they also give it because it dries out the secretions.
Yeah. So just gee whiz. Sometimes you'll see guys when they'll try to intubate the pediatric, and they're really trying to. And we'll talk about this. They really kind of don't want us to intubate them because they're seeing that pediatric after pediatric after pediatric, there really hasn't been a major outcome change in having them intubated or not intubated. But remember when the very first thing that John said, pediatrics, scary, scary, scary. Well, why? Because they're so low frequency. They are brand new cars. They shouldn't break down, right? So unless they've got a genetic disorder or something they were born with, or they've gotten into something they shouldn't be into, we don't see this happen very often. So I don't believe you'll ever give atropine, but it's one of the drugs you need to know. And it's got a couple little nuances. It's 0.02. Okay? Everyone go with that? Okay. All right. Diphenhydramine. Okay, so if you guys want to look at your District 2Bs, I think some of our drug dose says, I think the book says 1 milligram, and a District 2B is 1 to 2 milligrams per kilogram.
District 2B is 1 milligram per kilogram with a max of 50.
Okay. So what does the drug book say? Diphenhydramine.
Repeat dose,
Yeah,
1 milligram per kilogram.
Up to
Okay, so-
25.
up to 25. Okay, all right, cool. So, on this one, this is, you know, I'm just gonna match our books that are what I don't like.
I'll do that down if I need it for.
Yes, you're good, good. Our own current slide. All right, so we're all good with 1 milligram per kilogram, right?
Yes, sir.
Okay, cool. All right, you can't go wrong with this one. You can give it IV. Looks like our drug book says max dose of 25, and our District 2B says max dose of 50. Well, remember, this is an over-the-counter drug, right? Just you decide what you want to do, and the biggest thing is, and I don't know, again, I do these little things to help you remember, and you might say, yeah, Burst, he's a little bit off, and I really am. But, so, your T cells are kicking out these histamines, right? And they are just like, they're very flamboyant, and they're like going, histamine, histamine, and then throw histamines everywhere, right? And then your Benadryl says, boom, stop that. That is disgusting. Don't do that anymore. Okay? So your Benadryl knocks that down. Make sense? And I don't believe you can overdose yourself on well, you can overdose yourself, but not at 25 milligram to 50 milligram. So 1 milligram per kilogram. So let's go with that. All right.
Why are the UFA protocols different than the 2B?
Okay, so here's the thing. Every time we have a meeting with a bunch of paramedics, they're like, oh, we got to do this different, we got to do this different, whatever. Okay, and then, no, let's talk to Dr. Rowland, let's change this or whatever. I want to do this, because you get maverick paramedics out there that do stuff that they probably shouldn't do. Okay? But the thing is, they're practicing medicine, right? And then some of us want to have a written policy for every single thing. If I see this, I have to do this, which is an algorithm. And right now, start memorizing your algorithms. That is your safety and your protection. So, if you follow the District 2B and you do everything on the District 2B, then you'll never get in trouble. But then there's sometimes we swag, right? You get about 4, 5, 6 years you start swagging as a medic. Okay? Well, some try to do it 1 year, but then they get in trouble.
So on the 2B, it's higher than what UFA is saying. So we would be okay to go to 2B even though our own internal drug card is
Yes.
half of that.
Yep.
Okay. As long as we can point to something and say, I'm following this.
Yes. And point at it all day long. All day long.
You could potentially have issues internally just from the organization, right?
Yeah. Well, okay, now, you will have preference over procedure. Okay? So some guy's going to light you up and just say, this is what it says. I'm following my
But you
protocol.
can explain and say, but here were the
Yeah.
circumstances, this is why I felt
Yeah.
like you had to go up to
Yeah.
the 50 milligrams. And that's allowed by 2B.
Mhm.
So,
And so you have a range or a swag, okay? And, you know, like I said, maybe I just need to fix my drug books again. I don't know. You know, but it is so hard. That drug book is a living document. Okay? All right, so cool. Everyone good with, 10-year-old, how much are we going to give diphenhydramine?
25, 30.
Okay. All right, not that big a deal, right? Or you go 30, right? That's it. Or if you want to go 1 to 2, then that puts you up to what? 2 times 30 is 60, so you can't do that. So the highest dose is 50. So really, your range stops around 5-year-old when you start doing that. Okay? Okay, so epinephrine. Okay, we got some of these ones. Okay, so epi and using epi right now you're seeing, okay, there are so whole bunch of things that I can use epi for, right? And you have to start, you have to know how to ride your horse at this point. If you start messing around with your epi, you better be professional at it. So, just a couple things with us. We have our epi that is syrup in the back of your Maverick, and then you have your epi that is at the front, your Diet Mountain Dew. Okay, this is your syrup, Diet Mountain Dew at the front. Okay, so this is watered down. This is your syrup. But in our pediatrics, they're worried that we're going to kill them with the syrup. So never pull the syrup out unless that's all you have, and then you have to water it down. You have to do the math in your head and everything else. But everybody should have one of these in their box, right? Everyone should have a 1 to 10,000 instead of 1 to 1,000. So always use your 1 to 10,000s. Then our dose always is 0.01 milligrams per kilogram, right? So anaphylaxis or IV, they want 0.01 milligrams per kilogram. For sub-Q, I need to take that one out too. So asthma, we don't do sub-Q, we can go IM. Okay, 0.01 milligrams per kilogram IM. Okay, all right, and then 0.5 milligrams 1-to-1 nebulized in 3 mil, but it's easier. So for pediatric, you're going to cut that. It's not easy as 1, 2, 3. It's half the milligrams, happy 1-to-1. And 3 mils for crew. For cardiac arrest and IV, we're always going to do cardiac arrest 0.01 milligrams per kilogram, which you've already gone over. And then for shock, I've never had to treat shock that way. They talked about an epi drip, right? 0.1 to 1 micrograms per minute for shock. That'd be putting in an epi drip, and that's when I'd actually easy as 1, 2, 3, put 1 milligram. Epi 1-to-1, 2 milligrams. No, sorry, that's a different one. So it's 500 cc's. You do epi 1-to-1, 2 milligrams, and 500 cc's. But then you have to do it by a drip, and I wouldn't do that. So for us, don't go into your don't give it for shock. That would be something you have to contact medical control for sure, okay? And then tell them what you're going to build, and then how many drips per minute you're going to use. And you got to use a 60 drip set, okay? So that's the one I wouldn't do, okay? I might even think about taking it out, but we still have shock that we have to treat. All right, everyone good with epi though? Does anyone have any issues with epi?
So we're still 1-to-1 for anaphylaxis IM. Correct?
Yes. Well, for anaphylaxis, where is my anaphylaxis? So hypotension, 0.1. Yes.
It doesn't differentiate 1 to 10 or 1 to 1.
No, it doesn't. So, if you're going to do 1-to-1 IM for anaphylaxis, then you need to use a 10 cc syringe. A 1 cc syringe. A 1 cc syringe. Okay? And then in that 1 cc tuberculin cc syringe, you'll be able to get your 0.1, 0.2, whatever. Okay? And you want to do that with 1-to-1. All right, should I pull up a 1 cc syringe so you guys all got that in your head?
And this is on our 2 protocol for the epi on anaphylaxis. It just says 0.15.
That's because of the auto inject pens will reach a 0.15 or 0.3.
Yeah.
It's 1-to-1, right? So it's just
Yeah.
0.15. Just draw it up.
Or on our, we pull it up in our syringe.
Yeah, so you don't have to.
1.3.
You don't have to do math for it. It's
Yeah.
0.15. If they're over 25 kilograms, it's saying to give them the adult dose. Point 3.
Yep, and so, okay. Where does my adult dose come in then? Let's do the math then. At 5?
Yeah,
10.
10.
At 10. It'll be 0.3 then. So when they're 10, you're gonna give them the adult dose. 3 to 5. You can go have them go, the 3 if you want to. I don't see the point in. So your epi in that situation is a quick take care of the airway, open everything up, and then your Benadryl comes second as a long-term thing to knock down your histamines. Okay? So I wouldn't reach for my Benadryl first. I go epi and then Benadryl when you're going down that'll take away the itching, the swelling, and all that other stuff later on. And it's a slower acting drug. Okay? All right, cool. Glucose. Here's another one at a weird one. 0.5. Okay? All right, so glucose. If you have to give oral glucose to a 10-year-old, go.
What's the strength of the glucose?
What?
Or is this
We're talking
25 or
50.
50 or?
No, this is
or just
oral
glucose?
glucose.
Oral.
Well, either 15 to
1 gram per kilogram.
If we're going 1, we're doing 30 for a 10-year-old.
Yep.
If you're going 0.5, then you're only doing 15.
That one's pretty easy, right? And again, have your book with you if you want to look it up, that's fine. This one you don't do very often. Usually they're not unconscious. It would be somebody who just maybe had a new onset of diabetes, or maybe someone who is starting to work their routine out with using their insulin.
So our max dose is 25, so we won't exceed that.
Yep.
It's 25.
Yeah, can't go wrong on that one.
Pretty much after 5.
Okay, our next one is naloxone. All right, that's another one, can bring you back alive, so 0.1. Everyone good with that one? All right, anyone have any issues with doing the math? Okay, cool. And then normal saline. Yeah, normal saline. So our bolus is always 20 milligrams per kilogram, and our indications are for IV fluid therapy.
20 cc's.
Oh, did I say? Yeah, 20 mil. Yeah. Let's do that. Milliliters and cc's are the same, but I like 20 cc's per kilogram. Because milliliters are more about how much the drug is instead of. Normal saline, cc. Okay, and then last but not least, we've got oxygen. And again, putting oxygen on is all easy. You want to look between 94 and 99%. We're not trying to get 100% out of all. Okay, and for pediatrics, what are some ways, some creative ways to get oxygen on a kid who will not put on a non-rebreather, who will not put on a nasal cannula? What can we do as creative ways?
Give the mom. Give the mom, or even maybe
Now the
have
mom
them hold it.
you just cut off the top of that thing and just do blow by. You can tape it to their crib or their carrier and just let it blow into their face, right? But just remember, it's oxygen and be careful with the oxygen. All right. Okay, sodium bicarb. I love this stuff, but it's now out of favor, and UFA is no longer using it. And pediatrics, they don't want to use it anymore. So PALS has come out and said, don't. So when we talk about our H's and T's, the hydrogen ion or the acidotic nature of the body, they're saying that you can take care of that with your oxygenation, your IV fluids, and good, CPR.
Okay.
That's going to take care of your hydrogen ion. Okay. I'll give you an example. So we're working this little boy. He's probably only about 10 months, and we're in the middle of nowhere out in BFE, Goshen, Utah, right? For some reason, the sheriff says, well, I'm going to call a helicopter, you can go right ahead. But we worked this kid for 50 minutes. And then we'll talk about this because I'm going to use the same exact story with the IO situation, because there was some IO problems after that too. So we're working the kid, and the nurse gets there, and she calls the doc, online medical control, and the doc says, we'll give her sodium bicarb. I'm like, we're not supposed to do the sodium bicarb with the pals anymore. And so she said, I know, but the doc said to do it. I'm like, I just don't think we should, but okay, the doc said to do it. So we give the kid bicarb, boom, heart rate goes up to 140. He's alive now. And then we put him on an epi drip. They fly him off. He lives for like 2 days and then dies. Okay? So I'm not God. I'm just telling you that I got his motor running, but his electrical system's fried. Does that make sense? So great, I got a great motor running, but I do not have a good electrical system anymore. It's gone. So I think that's one reason why they decide after you've worked him a certain amount of time, don't give it, because it puts him in an alkalotic state where we can't bring him back from. And the other one is, I think I've saved a lot of people that I feel bad about doing. That was one of those ones that, this is one that just kind of sucks. The other one is a tricyclic overdose. Don't really have a lot of those anymore because they're not prescribing those meds like they used to. They still do, but and the only other reasons why we'd use it is someone who was like compressed under a car, someone who's stuck upside down in nutty putty caves and gonna die anyways, you know, that type of person. So so sodium bicarb is now out of favor. Okay, and you really can't see this one, but our pulsus arrest, it goes VTAC, VFib, asystole, and PEA. And I'm just going to go really quickly through our algorithm because this is how quickly it's going to go. Everyone doing okay still? Mm-hmm. All right. Okay, so when we look, we do our shock, and it is 2 joules per kilogram. I know you're like, holy shit, now I got to figure out all this stuff, right? So it's 2 and 4. Never have to remember it again. 2 and 4. We're going to shock them. That's what I'm going to do. 2 joules per kilogram. You know, they'll do things, say, well, you know, we can do 1, 1.5, whatever. Don't even think about it. 2 joules per kilogram. If they come back, well, start CPR immediately. Check your rhythm, and then if they aren't doing too well again, you give your epi, and then your next shock is at 4 joules per kilogram, and then you max out at that. Your epinephrine's going to stay at 0.01 milligrams per kilogram, and then we can do our amiodarone, right? Gosh, that was really small. Oh, but I can see it better with my glasses. So you give your amiodarone. If you do it in your tracheal tube, we're not doing that as much. If you shock again, you still stay at the 2 joules per kilogram. I mean the 4 joules per kilogram. And then you can start using your amiodarone. And then you work them. If that's as long as you have VTAC or VFib, so some sort of rhythm. VTAC and VFib, okay, so for pediatric, you're not really going to have VTAC, because VTAC is a broken down 1976 Chevrolet pickup truck. Or, unless mom says, they have some really bad problems with their ventricles, okay? So you're usually going to see VFib with pediatric. And VFib is very survivable when you got a brand new car, okay? So work that one hard. If it's asystole or PEA or unorganized, so PEA means the heart is trying to pump, but it's locked up because it's doing this, but it's not doing anything because it doesn't have anything coming in or coming out. So unless you can get blood to there, or they've either gone into shock or they've bled out or something's going on, that's PEA is something when there's no fluids moving through the heart, just electrical activity. Okay? Asystole, it's done, laying there down. Okay? So with that one, it's all about first drive, line drive. Always about epi, right? And are we shocking it? Nope. We're epi, CPR, epi, CPR. perfect, done. Okay? Anyone, and then when it goes down the bottom, your H's and T's, again, we're thinking about all those things, but your hydrogen ion is no longer, we're not thinking our sodium bicarb, we're thinking our, airway breathing circulation. Okay? Okay, bradycardia. So we have a slow heart rate. Again, it should not usually be a block. It's just going to be a really slow heart rate. When do we start CPR? At what rate?
Under 60.
Under 60. Or if they're really sick, if it's like 66 and they're blue and they're listless. Okay? Let's see. So we do there. So, but first, before we do any of that, we're going to go and we're going to do our airway breathing circulation. See if that heart rate is going to come up.
So O2 and IV first.
Yep, if we can do that, but we don't go longer than what? We're not going more than, 30 seconds. We're going to, the IV is going to take a minute, right?
Right. But oxygenate them for 30 seconds.
Yep,
IV gets the fluids and then go from there.
yep. And then if they have, if they look like they're compromised because of cardiac arrest, we go ahead and start the CPR. And if it continues, our bradycardia, we support with our oxygen, and then after that we go with our first line drug is always about Epi, and then our second one is atropine. Again, I don't think you'll get that far, but you know it's there. And you know what it does to the heart too. It whoops it pretty hard. If they go into pulseless arrest, you're going to just follow our PEA or VTAC VFib algorithm. Okay, cool. So the last one is tachycardia. So we have two tachycardia ones. One that is narrow, which should be okay, or one that's wide, which means they're sick, some sort of weird sickness, or a drug overdose of some sort. You won't really see this, and when it says 0.08, how many boxes is that? There's little 5 boxes and 1 box on your ECG strip.
So that'll be 4.
Mm-hmm. So you'll see it's wide. Wide is going to give you, in your mind, you're like, what, wide? What's going on here, right? So it's either some sort of poisoning or, again, some broken down ventricle problem. Or something that's congenital that they're born with. So if it's narrow, then I'm going to see what are the possibilities. So get their history. You probably won't be able to see their P waves. Infants, if their rate is over 220, you need to get aggressive, and if it's pediatric over 180, you need to get aggressive. What you do first is search for the probable cause. What they have? Did they drink a bunch of Red Bulls? Did they get in mom's pills? Right? Did they get in their dad's Adderall? Something, right? If it's sinus tachycardia and below those ones, we're not going to do too much supportive care. If it's over these 220 and 180, then we're going to go and we're going to call it supraventricular tachycardia. Again, consider vagal maneuvers, IVIO access, and this is where you stop because you can't give adenosine or synchronized cardio. But now you know what the clinical course is, right? So if you know that this is where it's going, you'll have it all ready when the engine arrives in our organization, the way it's going. All right? So it really goes down to fast, no, and slow. So fast heart rate, no heart rate, and slow heart rate. And if you put it that simple, it's as easy as 1, 5, and 10.
Cap except for us now in the ambulance.
Yeah, when the ambulance arrives. Yeah, okay. Yeah. Geez. They'll be good. Okay? Okay, take a break, and then we'll go to IVIOs, and yeah, then we're good. Hello, Lane Hilton.
Need you real quick, sir.
Okay. Okay. Dr. Rowland said they can, once they get their green patch, they can function as a green patch from now on. He has no problem. problems with that, as long as you follow the District 2B protocols. Okay, you need to take me for a walk? Lane?
You gonna need John?
No, John's good, if you need him for something.
Can I still use John for 5 minutes?
Sure. Well, so at this point, get that study guide thing that we talked about.
I got it.
And start hitting it hard. Oh, and guys, I was just gonna give you a take home, not, it won't be today, it'll probably be on Tuesday, just a take home, kick your own ass test. You can take it and have fun. I think it'll be like 100 questions.
Just like practice finals.
Yeah, so something kinda like that, alright?
I don't know enough.
No, I'll just give it to you paper wise. But it'll be something to make your toes curl or, make you feel, it'll still kinda suck. It has no, it is your own extra credit if you like. If you turn it in, I'll give you extra credit for it. Okay?
Hair color is good.
I think I've been wearing a hat forever, because
I know, I don't think I've seen you that.
I'm just getting, whole marriage thing's freaking me out, I think.
Already?
No, just about, it's like, it's your identity again, you know? I was like, I don't care, I'm not combing my hair, put a hat on. It's just like, you should, when we dated, you used to cut your hair short, I'm like, yeah, but I just like getting out of the shower and now I just go to my bar. Well, the other issue is, so my son, my gay son, cuts hair. And for him, for me to go to him is like $40. For me to go to the barber in Spanish Fork is $12. but I still need to have like, you know, sun time, so where, you know, so I can sit and talk to him, you know, he's my barber. And so, he
Doesn't
cuts
cut
my.
you a deal?
Well, he would do it for free, but it's my son, so I just, you know, I pay him 25 plus $50 tip, right, just 'cause he's my son. But it's like, he wants to do it all, you know, goo and stuff and make it all, and I'm like, no, I'm just okay with it just being short, wake up in the middle of the night and not worry about it. But that's where I'm struggling. It's my identity right now. Do I let him cut it and spend $40 and put goo in it, which I don't really like putting goo in it.
You have to keep up the goo every morning.
Yeah, and it actually takes like 10 minutes, and I hate it. And I'm sitting there combing my hair for 10 minutes. So it's like, I don't wanna do that. That's why I'm just, you know.
So then your wife,
And she likes it combed.
Just buzz it.
Well, that's why, the problem is I have this bump on my head, and I'm self-conscious about it, and so it's not a perfect head. And I don't like showing it.
you have nice hair, so you
Yeah.
should keep it. Yeah.
Yes, the bump is the problem, guys. Too much information, but there you go. Psychological problems occur everywhere.
Yeah.
Pictures going out, some of the TikTok people.
Oh, DP gate?
Yeah. Some of the.
All of the memes?
Unsolicited.
Yeah.
Unsolicited. From?
We don't know.
Yeah, I haven't heard anything.
From somebody to. Here it is.
The last email.
No. Although that was fun. The email last night was quite interesting. And then have you guys seen all the
What was the
memes?
email last night?
You know, from Jason Jones?
Wow, I haven't done this.
And then all of the memes that came with it. Yeah.
Oh,
Have you seen any of them?
so I saw his email that went out, and then Fitch immediately
Yeah, I was working with
withdraws his
Fitch.
bid.
No, he was kidding. Like, we were sitting there.
Oh, so
We
that's
were,
bull?
that was a
fake?
joke.
Yeah.
That's why he replied all. It was a
Oh,
joke.
okay.
Because he actually has put in a bid, but he was joking. I was sitting next to him and sent it.
Yeah.
He's like, I'm withdrawing my bid because my skill set isn't up to par. And that was, so, and then he got an email or a text from Chad Hogan and said, no, you're fine, we would love to have you here, it's not a big deal. I didn't send that, I didn't mean.
Tell staff has grown.
Yeah.
But he got, so when he sent that out, his phone blew up, he got 88, 89 memes, everybody just
Oh, okay, but I mean all the memes.
varying from a Jedi 1 saying, this is not the bid you're looking for, to just a ton of them. It was hilarious.
Did not kill me so. I laughed so hard.
35 years.
It was so quick. Like a couple days afterwards.
That's kind of funny.
So the next.
All right, so these next ones we'll go through real quick.
Hilarious.
All right, at this point, is everyone feeling comfortable about doing their ILs? The biggest thing at this point, so in about 2 weeks, we're gonna and we're gonna do all of these national skills. And all I can tell you at this point, now I'm not giving you a bunch of tests anymore. Try to get ahead of the ball game and finish up your quizzes for the end of the year. And memorize those things word for word. And then you'll have it down. That's kind of easy, that's an easy part, but that'll be our biggest focus from now until well, it'll be about a week or so. Still gotta go over OB. And then after OB, we're gonna hit that pretty hard, okay? So I'm gonna give you some indications and some, pictures. I got some cadavers here, of some pediatrics, and why it's important to make sure that you're using your IO properly, okay? Okay, so, when we do IV with our pediatrics, they're really, really tough. I don't know if you were, actually if you were able to at St. Mark's, and you probably wouldn't have very many opportunities to do an IV on a pediatric, right? They're hard, and then I've gotten mine throughout the years, but when a kid is in compromise, in shock, and out, you're not going to get a vein. And if you go to primary children's, you'll see they have a nice they'll warm their hands, or they have this little light that comes up and shows you where the veins are. We can actually buy a little tool that can find veins, like Provo City bought one for all their rigs, but I'm like, okay, I don't know how we're gonna do that either. Usually the IO access thing is because this kid is out and needs resuscitation right away. So we know, here's a good picture of your peripheral places to get IVs. Nurses prefer that you hit the hand first, strike 1, strike 2, and then on your AC, and then you can go to your IO. But we're going to really kind of hit more IOs here in a minute instead of talking about IV. So you get 90 seconds or 2 strikes, you're out. Then you're going to IO. Okay? With a severely compromised pediatric. Everyone go with that? Some guys don't even bother and go straight. If the kid is 3 things. If they are listless, or that pediatric triangle, which we'll go over a couple more times before the end of the class. If they're not looking at you, if they're hemodynamically compromised, they have an altered level of consciousness, just go straight for the IO. All right? You have to do CPR on them, and the IO's the best choice. I don't like this picture so much because almost every single one between your knuckles has a vein that comes through, but you're getting them a little bit higher. But you can start in between your knuckles, and then you can usually find a vein if you go up from the in between your knuckles, and you can usually find a vein. Bifurcations are really good. So this is a bifurcation on your hand that I really like to get after because I've got a nice place to hit right in the center of it. So bifurcations are kind of nice. Again, it's hard to see on pediatrics. All right, so our biggest thing with our pediatrics, we want to stay off the pediatric growth plate. This doesn't really show it very good, but our growth plate is right on here and here. And we have some places where we can get after is the tibial tuberosity, which you're going to be learning about and you've memorized how to do. But then there is also the femur, which you can go up a little bit higher, and we've only used that twice, and because the tibial tuberosity failed, and I was pretty mad about that. Okay, so they'll talk about making sure we secure it pretty good. It's supposed to be like a self-tapping screw that self-taps in, but sometimes it'll slip out. And I had it slip out on me one time, and I did not like that at all. It did not make my day go very well. So the biggest thing is to stay off the growth plate. So when we look at our easy IOs, we're always thinking pink. Okay, pink is for pediatric. this is the hole created by an EasyIO. And again, we use, if we look at our kilograms, so right there, a 10-year-old is what, 30 kilograms? So 40 kilograms and greater, we use blue. So pink is always going to be our first choice for anything under 10. Make sense to everybody?
Yep.
Okay, cool. And I actually like that picture because it looks like, no, that's not a 1-year-old. That's more like a 3-year-old.
Kurt,
Yes.
they've kind of changed that.
Okay, go ahead.
Pink one is for like 30 days and under.
And then want you to use blue for the other ones? Well,
There's
maybe
a
that's why
third
it's fell out.
size.
What?
There is a third size now.
Yeah.
Well,
The
yellow.
bigger,
Yellow.
fatty.
Yellow one.
Yellow's for
Yeah.
fatty
Yellow.
fatties.
For big,
Yeah.
Or humoral.
Mhm.
that's for,
Yeah.
So,
You could never put a pink one in a 39 kilogram fit. It wouldn't even touch the variosity.
yeah, they're too big.
Way too small for that.
Well, we probably need to do an in-service on that one, cause that's, I don't know when the last time we've had a good in-service on one, but,
Yeah.
but I will say, that makes sense with, when I tell you how horrible this call went, okay? Cause it was horrible, and I was not like it at all. Okay, so, also, you can use a Brazil tape, and it will help you as well. So what does a Brazil tape save on a 10-year-old? Does it have an EasyIO on there? That'd be probably the longest one, the very one at the very end, probably.
for 10-year-old, green.
Yeah.
9-year-old, yeah.
Does it have an EasyIO size?
Negative.
It just has the gauge, which doesn't help us, doesn't have length.
Yeah. 15. They're all 15. 15.
15 gauge?
Yeah. It's the length.
Okay, then one thing I do want to go back to, and I'll show you this in a second, I don't know, okay, these lines though, and for sure, I can tell you with 100% certainty that when your line goes in, when you find your spot, right, you insert to the first line, and then go to the second line. All right, so if you insert and you're already at this line, you might be having a problem on a peak. Sorry. Yeah, on a peak, right?
So if you push it in, you're already buried just in the fat on that line, you're not.
Yeah.
You're drilling.
Yeah, it's not gonna.
Yeah. So those lines, the lines are really more of a gauge of you go to your first line and get it to your next line. And then the problem with that is that then you have to secure it really well or it pops out. So you might have a little gap there, and we'll talk about how to secure that a little bit, okay? All right. Okay, so indications for EasyIO, they're usually for emergencies. The one was cardiac arrest, hemodynamically unstable, blood pressure less than 90, imminent respiratory failure, epilepsy that doesn't stop, or status epilepticus, and then toxic conditions, or they need an antidote quickly, or and just any other pediatric guidelines. Contraindications, if there's a fracture in the bone at that site, don't use it. Previous ortho procedures or insertions, or where they have obviously prosthesis. I don't know if you can put it in the wooden leg, right? I don't know if you can do that.
You can put it in.
Yeah, you can put it in. I don't know if it worked.
Not doing anything.
You mean it's not gonna slide the bottom from there?
Right.
Okay, so I've made a bazillion mistakes in my career, right? So this guy, I go on him, and he's been in a car accident, and he's got a wooden leg, all right, from the military, full on prosthesis, whatever you say. So I'm doing my full assessment on him. I knew it, I saw it, I went down and pinched the one foot and said, am I scratching or pinching? And I go, am I knock, knock, am I scratching or pinching? And he looked at me and I'm like, oh, that's funny. Okay, so, anyway, so it was just something stupid that I did, but anyway, there you go. Okay, so, if there's infection at the insertion site, we wanna go in that. Excessive tissue at the insertion site with, that there's something wrong anatomically there. And then, landmarks are hard to find. So there's 3 sites we can go after, but we'll talk about them. So the FDA has cleared your proximal tibia, your distal tibia, and your proximal humerus. But they also, and I didn't really throw this one in there, and I threw it in, you can do the femur, as long as you stay off the growth plate. But I don't know what our protocols say about the femur for us. Go ahead, Johnny.
Distal femur.
Yeah, the distal femur, yep. So the one, instead of going to your tibal tuberosity, you're gonna
But
go.
that's only for kids.
Yeah, and it's only for kids right here, all right? Because there's a big fat bone there. All right, so again, I'm gonna go on to the next part, and again, these are cadavers, they're real, so I've showed you some of them already, but just so you're aware. All right, so this is a toddler, a 17.9 kilogram male. So how many pounds?
10.
Yeah. So 17. So yeah. So 17 kilograms. So it's probably. Did I say the age? It's toddler, probably around 3. Okay. So again, can you see the 17.9? I just bring that up. It's all a swag, right? You don't know if they're really 20 kilograms or if they're really 17.9, right? So that's just something we just kind of, I just want to kind of drive into your head but again, the Brazil tape is your best option in making sure everything's accurate. So we have the distal femur, which we can do on pediatrics. We have the proximal tibia. We have the distal tibia, which is kind of a hard one to hit, but you can use it. And then you have your proximal humerus. And actually, that's a really good site. I think, like I said, for us, you can find that by taking your patient and just moving their arm like this and feeling for it. You'll feel the head move around, and once you find it, you're good. The other one is your thumb to bum, but you're never going to take your patient and stick their thumb in their bum, because I'm trying to find your humerus head, right? But that shows you a good place where it's at. Okay. Again, it kind of shows you your gun. The gun is for this is a multiple use. They don't usually go bad, and you don't need to test them every morning when you open up your drug box. You don't need to go, they're good, because you're using the battery every time you go, so don't do that. We want to stay off, again, our growth plates, but you can go for your proximal tibia, your distal tibia, and again, it is now, the site is now cleared to your distal femur. What's that saying? Proximal what? Go ahead.
If you do go to use the driver and it's dead, you can still manually insert this needle.
Yes. So in the olden days, it's called a gem sheety.
Right.
And it is a mean. This sucked because you would actually pull it out and you sit there and push it in and drill it till it popped in.
Like for the sternals?
Yeah. And so I know when the first time I used the Easy IO, I thought it would be more like a nice drill. You drill it in and suck in. But I'm sitting there drilling it, it goes, and I'm like, I pushed on it and then it sucked in, So I was like, so you have to put pressure on it to push it in.
Not a lot.
Yeah, but yeah, you don't have to jam it in, but you do have to push on it enough for it to bury itself in the bone. Okay, so Here's your side cuts, where we're looking at. Here's your distal femur. Damn it. Nice big bone, right? And you're gonna be going through and you're shooting for here. Your proximal tibia is one we're always hitting. We're always getting after this, but it's pretty close. It's your needle is gonna be longer for your femur than it will be for your tibia, okay? And then again, your distal tibia, you can still use that even shorter. So you don't have to go very far. This is where you really got to start looking at your black lines, okay? The biggest thing on this one they're showing on our needle, if you bury it and you can't touch anything, this is wrong. So go to your first line and then bury it to the next one. Next line in order here. If it's in your femur, I'm pretty sure you could probably make it go all the way through, but when you're in your tibias, then you're a little bit worried. You don't want to go all the way through, okay? So, just a couple things. See, and when you look at the meat on here, that's why we're not trying to get our fib or fibula, and our tibia is the closest and flattest space right here. So just realize that you could, there's a lot to miss. So you really do need to find your landmark. And then when it shows you here that you've got the needle going in, the pink is very, very close to not being all the way in. And so here's the second way of doing it, burying that and then going to the next line. So you have to practice medicine when you do this, okay? You can see here too, this is going to be my distal tibia, and again, they had to use almost 2 lines, where my pink one only has 1. Okay, so our humerus, again, it's kind of hard to find, but they're showing where you're putting that in, and then you're going through the arm into there. So again, it seems like not a good shot, because it is kind of small, but really try to find that hard bone, and then go into that bone, right? So if you can take that out right here, it's going to be right here, and you can go right in. All right, so everyone, if you want to feel each other's humeruses, that'll be good. And then, again, on our proximal humerus, you're about 11 millimeters. And look what size they're using. They're using the blue one because it had to go pretty far into the arm. Okay, so a couple things. They just did this on a juvenile goat. Just a quick how fast the contrast goes in. So anything you can do IV, you can do IO. All right, everyone good with that? So this is the picture. I think this goes in my time. Come on. I thought I had time stamps in the corners. Guess not. So there's your easy IO. I thought I had those. Okay, well, this is when it goes like within 1.03 seconds and then 1 second, and you can see how when it first starts, there's nothing in the line's coming in. As soon as it gets there, it goes into the meat, and it goes real quick. I have a better video, though. I'm going to show you the video because I like that better. This is a view of the femur, and so once I got it in, it was pretty quick. This is the left femoral, and it goes in pretty quick, and how quickly it comes out. And I guess I really don't like these pictures that much. Again, it's showing on your femur here how many black lines you had to go through to get there, and there it is on the ped. Again, you got your femur picture again, and then with your needle. Stay off the growth plates. So if you decide you're going to the femur, you're going to find the patella, and you're going to go back at least a thumb's worth. So your thumb off their patella, you can do that 1, 2, and then up. I just roll my thumb. Okay. Okay, so here's my story, right? So we went into the proximal tibia, and we're doing CPR, and we're working CPR, and then all of a sudden I realized that this has popped out. So we put in another one in the distal. We're working on that, and it comes out. And then the nurse put one in the distal. She tried to go back into the other leg. No, that was it. We did it on the proximal tibia one side, proximal tibia the other side, and then she tried the distal tibia, and then she went to the distal femur. And this is the same kid that we gave the sodium bicarb to. He came back alive. So you got four hits to the bone, and we were on back alive. So that was a tough day. I'm going to show you the video really quick, and then I think we're done.
What do you think the cause was that kept falling out? The needle too short, or?
I think the needle was too short.
Yeah,
so I'm
that
gonna go
fake needle,
Yeah.
you really shouldn't use on, the maximum age for that is like 3 months. If they're over 3 months old, blue. And if they're a chunky 30-day old, go to blue.
I don't know if this is the one or.
Because they have a horrible tendency to fall out because they're short. They're actually designed for what do you call them? Freebies.
All right, this wants me to open it with something else. Let's see.
Neonates.
Okay, I think I was going to bring it over. Burr.
If you want to see some really good videos on IO insertions, go to the Teleflex site.
Yeah, and I'm not being able to pull mine over to that other screen.
They've got some really good videos on IOs.
Okay, never mind. Let me see if I can do it with my. Okay, here we go. So it goes really quick. So you see how quickly your drug is right in the system that fast. Play it one more time. Let's go back. And it's like 10 seconds. Okay, it's 11:30. Everyone good to go? Do you feel like you learned something today?
Who
Okay.
hasn't done needle decompressions yet? Has everybody done needle decompression?
You know, what we can do is we can, when we pull out our skill sheets, we'll let you guys do needle decompression.
Okay.
Here shortly. So it's, I was reading the other day, I was like, I'm totally wrong. They totally put it in the protocol, you can all do needle decompression. Okay? Alright, cool. I think you have to send it to me. Or just tell me what your score is. Okay. Yep, that's good. Okay, thanks guys.
Thank you, sir.
Yep.
Later, Gator.
Have a good one. See you guys.
Nice picture, Kurt.
Yes, it is.
Happy birthday.
She's my love.
You better keep your hair up, keep it hot to
Yes,
like
thank
her.
you. That was good.
We just finished teaching downstairs. We don't have to go too far. Do you want me to Oliver or Susan?